Yeah, we're ready.
The Subcommittee on Health will now come to order. The chair now recognizes herself for 5 minutes for an opening statement. First of all, welcome to the first legislative hearing of the Health Subcommittee in the 116th Congress. Last week we heard testimony and examined what the devastating effects would be if the case Texas versus the United States were to stand, most especially on those who have pre-existing conditions and the medically complex children who rely on the Affordable Care Act. We also discussed how the Trump administration's sabotage of the ACA and the expansion of junk insurance plans are driving up costs by diverting the healthy out of the individual market and weakening patient protections with pre-existing conditions. Today, the four bills before us address short-term insurance plans, waivers to weaken insurance regulations on the private market, funding for marketing and outreach, and legislation that would require short-term insurance plans to carry an advisory informing consumers what the plan does not cover and what ACA requirements the plan does not meet. It's a top priority of the majority to protect patients with pre-existing conditions. On the campaign trail and in our hearing last week, our Republican colleagues voiced their support for pre-existing condition protections. They asked for specific legislation, and that's what we're here to discuss today. Our first bill will rescind the short-term limited duration insurance or junk insurance policies regulation the Trump administration finalized last August, which expands these junk plans from the current 3-month limit, making them available for up to 3 years. We know these plans do not cover pre-existing conditions. They do not have out-of-pocket and lifetime limits, and they do not protect women from being charged more than men. Representative Castor's bill would rescind the rule that expanded these junk insurance plans. Representative Custer's bill revokes the Section 1332 waiver guidance issued by the administration last October, which weakens requirements of private insurance plans to provide comprehensive coverage at an affordable price. Section 1332 of the Affordable Care Act requires states to meet standards for what qualifies as health care coverage. The Trump administration guidance changes these standards to be less comprehensive and less affordable for patients who rely on private insurance purchased on the individual market. It also allows tax credits, federal dollars, to be spent on these expanded and extended junk plans. My Republican colleagues have been highly critical about funding tax subsidies to help Americans afford comprehensive health insurance, but support allowing more people to access federal money for these short-term junk insurance plans that do not even cover basic services. Representative Custer's bill rescinds that guidance so that all Americans will have health insurance coverage that meets the same standards. We're also considering a bill authored by Representative Lisa Blunt Rochester to restore the marketing and outreach funding the Trump administration cut by 90% in 2017 and banning this funding from being used to advertise the junk insurance plans. An article published in Kaiser Health News earlier this month described how consumers searching online to enroll in comprehensive ACA plans are most often redirected to websites and brokers selling junk plans without disclosing that the coverage will not be comprehensive. And I ask unanimous consent to enter this article into the record. Hearing no objections, we will do that. Federal dollars should not support advertising coverage that will not protect patients with pre-existing conditions. The last bill, my legislation, will require junk insurance plans to display upfront what is and what is not covered so that consumers will know exactly what they're buying. My bill also requires a disclosure that these plans do not meet the Affordable Care Act's requirements for cost sharing and lifetime limits and prohibits these plans from being sold during the individual market open enrollment. I want to be clear about the following. I believe the Trump administration's rule that expanded the maximum duration of these so-called short-term plans up to a year and allows them to be renewed for up to 3 years should be rescinded. I see that I'm over my time, and at this point, I would like to recognize Dr. Burgess, the ranking member of the subcommittee, for 5 minutes for his opening statement.
Well, I thank you for the recognition, and today we've been convened once again to discuss issues that will not improve the affordability of health insurance for Americans. Unsustainably high premiums and issues related to silver loading are increasingly becoming a reality for families that rely upon healthcare.gov for their insurance. Yet the bills before us today will not make a marked increase in the availability of reasonably priced plans. I am encouraged to see that we are at least discussing some legislative ideas today, unlike last week's hearing, which I think everyone agreed was an exercise in futility. Once again, I would like to make it clear that there is bipartisan support for protecting coverage for individuals with pre-existing conditions. Many on our side have expressed that sentiment. Certainly we have people that we know in our families or amongst our employees when we were before we came to Congress, or in our medical practices that are affected by the status of pre-existing conditions. But the constituents in my district are struggling to afford their health insurance, and I'm sure the district I represent is not unique in that regard. What good is health insurance if you are afraid to use it because you cannot afford your deductible? I have a lot of people that I represent who cannot afford a flat tire, let alone a $6,800 deductible in the bronze plan sold by healthcare.gov. This is the issue that I'd like to see us tackle, and I'm disappointed that none of the bills before us today will move that. What I find most troubling about today's hearing is that our colleagues are questioning the flexibility that they put into their own law. Section 1332 of the Affordable Care Act provides states the opportunity to apply for state innovation waivers. These waivers allow states to come up with inventive ways to insure their population while safeguarding their access to quality insurance. Section 1332 of the Affordable Care Act explicitly authorizes the Department of Health and Human Services and the Treasury Department to waive certain ACA coverage requirements. It is written into law. To be clear, I did not vote for this law, nor did I receive positive feedback from my constituents about the law's implementation. However, states like Alaska have had success with these waivers, which gives states room to repair their markets that have been damaged by the Affordable Care Act. This hearing is another attempt to distract from the Democratic Party's agenda to establish government-run single-payer health care. Last week it was said that there are other committees in the House that are holding hearings and drafting legislation to establish such a plan. On February 7th, the magazine Modern Healthcare published an article that says a draft version of the House Democrats' upcoming Medicare for All bill proposes a national system that would prepay hospitals with lump sums while keeping fee-for-service models for individual physicians. This news outlet obtained a 127-page draft that was dated January 14th, but I've yet to see such a draft. It is concerning that the media knows more than the members of this subcommittee about the details of this proposal. Based on what I have read about this supposed draft, I am concerned. I will tell you, as a physician, I know that the critical doctor-patient relationship is threatened, and I do not believe that the government should hinder a doctor's ability to act in the best interest of his or her patient. According to the Modern Healthcare article, this proposal would implement a global budget, and once that is set, hospitals and institutions would need to stick to it for all outpatient and inpatient treatment. So that's what's truly concerning about this. What happens if the budget runs out? Are patients told, well, we're sorry, we're out of money. Maybe you could try this again next year. This is a recipe for waiting lines. This is a recipe for rationing care. And the sooner people understand that, the better. Meanwhile, there is a greater percentage of Americans in employer health coverage than at any time since the year 2000. The number of Americans with employer-sponsored health coverage has increased by at least 2.5 million, and probably much more than that since President Trump took office. Where are the CBO coverage figures on the expansion of employer-sponsored health plans, because more people are working now than there were before the president took the oath? The President's Council of Economic Advisors projects that the administration's recent actions will create $453 billion in net benefits for consumers and taxpayers over the next 10 years. Again, as a holder of one of the so-called junk policies, I had a health savings account before the previous administration told me I didn't know what I was doing and couldn't manage it and took it away from me. I welcome the fact that the administration has provided this flexibility, and I'll yield back my time.
Thanks. I thank the ranking member. Just something for the record to the ranking member. I don't agree with your characterization of the last hearing that we had. Everyone does not agree with your characterization. I think your side does, but our side doesn't. With that, I would now like to recognize the chairman of the full committee, Mr. Pallone.
Thank you, Madam Chairwoman. Today, this committee begins to fulfill the promise we made to reverse the repeated sabotage of our nation's healthcare system by the Trump administration, in addition to make healthcare more affordable and to protect the more than 133 million Americans with pre-existing conditions. We'll be discussing 4 bills that will make a real difference in people's lives. The first bill, introduced by Ms. Castor, would reverse the Trump administration's regulation to expand junk insurance plans, known as short-term limited duration health insurance. The Trump administration expanded these junk plans from the current 3-month term and made these plans available for up to 3 years. These junk plans are exactly that, junk. They discriminate against people with pre-existing conditions. They set higher premiums for people based on age, gender, and health status. They deny access to basic benefits like prescription drugs, maternity care, and mental health and substance abuse treatment. And they set arbitrary dollar limits for healthcare services, leading to huge surprise bills for consumers. Expanding these junk plans also makes health insurance more expensive for people with pre-existing conditions by undermining the market for comprehensive coverage. The business model of the companies that sell these junk plans is to spend as little as possible on the health of their enrollees. They accomplish this by denying coverage of pre-existing conditions, kicking people off their health insurance if they get sick or seek medical treatment, and pocketing their premium dollars as pure profit. This profiteering at the expense of people's health is simply unacceptable. It's why we passed the Affordable Care Act in the first place, to rein in exactly these types of abuses by health insurance companies. And yet the Trump administration would give insurance companies the green light to once again discriminate against people with pre-existing conditions. Now, Ms. Castor's bill is an important step in strengthening the individual market and reversing the harm caused by the Trump administration. Ms. Escher's bill requires these short-term plans to bear a consumer warning. As we'll hear from our witnesses today, junk plans are often deceptively marketed as comprehensive coverage, and consumers are not always aware of the fine print. This is about a consumer's right to know. The bill would require issuers of these plans to display a clear, prominent warning advising consumers that the plan does not cover pre-existing conditions, is temporary, and may not cover most health care costs, and that coverage can be terminated when someone gets sick or seeks medical treatment. And I believe this bill works in conjunction with Ms. Castor's bill. While consumer disclosure is important, we must also prevent all of the problems associated with expanding these plans to 3 years. We'll also be discussing Ms. Custer's bill to rescind the Trump administration's 1332 guidance. Section 1332 of the ACA was designed to give states the ability to examine system reforms that would improve the well-being of their residents. The key word there is improve. States are also required to maintain the affordability and comprehensiveness of coverage and keep the same number of people insured as under the ACA. But the Trump administration's 1332 guidance turns the statute on its head, giving states the green light to undermine protections for pre-existing conditions. The guidance also gives states the green light to provide taxpayer subsidies for junk plans and reinvigorates ideas from the failed Republican repeal bills, such as the flat tax credits that do not keep up with rising premiums and shifts costs onto working families. This guidance is bad for consumers, bad for individuals with pre-existing conditions, and bad for taxpayers. It exceeds the administration's authority and is contrary to congressional intent. And finally, we'll be discussing Ms. Blunt-Rochester's bill to restore consumer outreach and enrollment funding that is so important to making healthcare more accessible and affordable. The Trump administration gutted funding for consumer outreach and marketing by 90%. The administration's refusal to invest in outreach and enrollment is making it harder for Americans to get health care, and this is leading to lower enrollment numbers. The administration has overseen 3 consecutive years of decline in enrollment, and new enrollment is down by 50%. And the administration's sabotage have resulted in the highest uninsured rate in 4 years. So Ms. Blunt-Rochester's bill would fund critical outreach and enrollment at $100 million, which was the level before Trump's sabotage. Her bill also prevents the administration from using these funds to promote junk plans. And her bill is an important step in lowering health care costs and expanding coverage to more Americans. Now, all 4 bills we're considering today are important first steps in lowering health care costs and protecting consumers with pre-existing conditions. And I commend all 4 members for their leadership and look forward to continuing to work with my colleagues as we make health care more affordable for all Americans. And again, I want to thank the chairwoman. I think this is a very important hearing, and this will lead to legislation being passed. Thank you, Madam Chair.
I thank the chairman, and now I'd like to recognize the distinguished ranking member of the full committee, Mr. Walden, my friend.
Good morning, Madam
Good
Chair.
morning.
Thank you for having this hearing. And as I said in the hearing down below, I know the Dingell family is in all of our thoughts and prayers this morning as they cope with this terrible loss of our distinguished chairman, for whom the big hearing room is named. And I know that he taught us all how to legislate. And despite, as I said downstairs, our best attempts to emulate his yes or no questioning, nobody else pulls it off like John Dingell could pull it off. So he is in our thoughts. So good morning. And given the title of today's hearing, I too am concerned for the second time in as many hearings in this subcommittee that we're really not addressing the real challenges that consumers are facing, which is the high cost of health care. Madam Chair, I said it last week, I'll say it again. We need to work together to help states stabilize health markets damaged by the ACA, cut out-of-pocket costs that consumers are having to pay with these high deductibles, promote access to preventive services, encourage participation in private health insurance, and increase the number of options available through the market. Unfortunately, today's hearings and these bills, I don't think are adequately addressing any of these goals. Why would our Democratic colleagues be opposed to states innovating on behalf of their citizens? Why would they be opposed to providing patient, flexible, and affordable insurance options that best fit those patients' needs? I just don't think it makes sense. The administration is allowing 10 million Americans more choices and more affordable health insurance options. The Democrats' Medicare for All proposal would force over 150 million Americans to lose their employer or their union-sponsored health insurance. And I think that's wrong. You want to talk about sabotage, that's what we should be having a hearing on is Medicare for All and what's coming. I also want to reiterate my call that the Energy and Commerce Committee hold hearings on that bill. So today, instead of having a constructive bipartisan dialogue about helping states innovate, about providing options for patients who are struggling to make ends meet, we're here for the second time in as many weeks casting the blame of Obamacare's failures on the current president. The fact is, we all support protecting people with pre-existing conditions, and we share a desire to stabilize an individual health insurance market. Last Congress, I advocated for policies that would achieve both of these goals, first through the HCA's Patient and State Stability Fund. And I made 2 more attempts at bipartisan stabilization reforms last Congress, working with my colleagues in the Senate. Unfortunately, House Democrats repeatedly blocked our creative solutions. Solutions like improving 1332 waivers to better meet states' unique needs and modernize programs to stabilize premiums. Now, in my home state of Oregon, which celebrates its birthday tomorrow, we have an active 1332 waiver for a cost-based reinsurance program. I supported my home state's application and approval as the only Republican in our congressional delegation. Why? Because it represents the very fabric of federalism. What works best for Oregon may not work best for California, Madam Chair. Take Alaska, for example. In studying their individual market, they found that a conditions-based reinsurance program would better serve their residents. Before they received a waiver, 2017 rates were projected to increase 42%. But after shifting individuals with one of 33 medical conditions into a separate pool, premiums for the lowest cost bronze plan fell by an astounding 39%. And in Oregon, the reinsurance program kept premiums 6% below what they would have been without it. These are real savings for patients in my state. Oregon and Alaska, one pretty traditionally blue, the other pretty traditionally red, found a way to take advantage of 1332 waivers to best serve their citizens. They're not alone. To date, 8 states have active waivers: Alaska, Hawaii, Minnesota, Maryland, Maine, New Jersey, Oregon, and Wisconsin. 8 diverse and unique states, but they have at least one thing in common, Madam Chair. That's each of these 8 active waivers were approved under the Obama administration's 1332 guidance. Yet today we're here to discuss nullifying the Trump administration's 1332 guidance. Why not first observe how states react and reform their markets through the new guidance? We should understand that better. Perhaps a better use of our time would be spent discussing bipartisan solutions to reform and improve these waivers. We all want markets that work. We do. We all want patients to have access to high-quality, affordably priced health coverage. Unfortunately, the ironically named Affordable Care Act has made insurance for many unaffordable. And I heard it again yesterday from wheat growers in my district. Together and with the states as partners, not subordinates, we can achieve the shared goals of well-functioning and stable markets that provide Americans affordable health care options. So one thing's clear: we need to guarantee our health care system works better for all Americans. That we can agree on. And that's why our goal should be to advance solutions to protect patients, stabilize health care markets, encourage greater flexibility for states, and promote policies to help Americans get and keep coverage. So, Madam Chair, thank you for having the hearing today. We look forward to working with you, and I yield back.
And I thank the gentleman. I now would like to welcome our witnesses for today's hearing. First, Ms. Katie Keith, the Associate Research Professor and Adjunct Professor of Law at Georgetown University. Thank you for joining us. Ms. Jessica Altman, Commissioner, Pennsylvania Insurance Department. Very important job. Welcome to you. And to Ms. Grace Marie Turner, President of the Galen Institute. We thank you for accepting our invitation to join us today, and we look forward to your testimony. And I'm going to, recognize each witness for 5 minutes to provide your opening statement. And just a little housekeeping, our lighting system, what's in front of you is a series of lights. The light will initially be green, and then it'll turn yellow when you have 1 minute to go, kind of like the League of Women Voters debates that we've all been in, right, with the lighting system. And we don't have a bell, we have a lighting system. And after that, you'll have 1 minute remaining, and at that point, the light will turn red when your time expires. Not when you expire, but when your time expires. So let me begin with Ms. Katie Keith. You're recognized for 5 minutes, and welcome again, and thank you to you.
Thank you very much, Chairwoman Eshoo, Ranking Member Burgess, and members of the committee. My name is Katie Keith, and I'm a faculty member at Georgetown University, where I study private health insurance. I'm also the author of the Following the ACA blog series for the health policy journal Health Affairs, where I'm responsible for tracking and chronicling implementation of the Affordable Care Act, including many of the changes that the Trump administration has made in recent years. My testimony today will focus on just 3 of those changes, although there have been many more than that, as you all know. The actions I'll discuss today undermine the ACA risk pools, leave consumers who become sick without access to health care, and drive up premiums for people with pre-existing conditions. I'll begin with short-term plans. Last August, 3 departments issued a new regulation allowing short-term plans to be sold for up to 12 months and extended for up to 3 years. Short-term plans do not have to comply with the Affordable Care Act, and they're allowed to discriminate against patients with pre-existing conditions. These plans are medically underwritten and do not have to cover entire categories of benefits. A recent study showed that 43% of these plans do not cover mental health services, 71% do not cover prescription drugs. In the midst of an opioid crisis, 62% do not cover substance use services, and none of these plans covered maternity care. Some had out-of-pocket maximums as high as $30,000 and lifetime limits on care. These plans, which are highly profitable for the insurers that sell them, tend to only work for those who are healthy. The harm to consumers from this new rule is twofold. First, these policies pose a significant risk to the individuals who enroll in them, only to find that the care that they need is not covered when they become sick. Many newspapers are filled with stories these days of consumers who have enrolled in these plans only to wind up facing hundreds of thousands of dollars in unpaid medical bills. Second, these policies drive up premiums for those with pre-existing conditions, particularly for middle-income families who do not qualify for ACA subsidies. Moving on to Section 1332, the Trump administration recently issued guidance that encourages states to offer skimpier coverage, including short-term plans. The new guidance relaxes a previous interpretation of what we refer to as the statutory guardrails under Section 1332. This could result in state efforts to advance less comprehensive coverage and drive up premiums for people with pre-existing conditions. It's worth noting that there have been questions raised about the legality of both the short-term plan rule and the Section 1332 guidance. The short-term plan rule has already been challenged in court in a lawsuit brought by consumer and patient advocates, including the Little lobbyists who I believe testified before this subcommittee last week. These patient advocates have sued over the rule because of its impact on people living with HIV, people with mental health issues, and people with other chronic conditions and disabilities. The 1332 guidance has not yet been challenged, but approval of a waiver under that guidance would likely be challenged quickly. Finally, the Trump administration has made dramatic cuts to funding for ACA marketing and outreach. This includes immediate cuts during the final week of the 2017 open enrollment period, followed by a 90% reduction for 2018, from $100 million to $10 million. Those cuts were maintained by CMS for 2019, and CMS has reduced funding for the Navigator program by 84%. These funding decisions were made even though outreach and marketing helps bring in younger, healthier consumers, which in turn helps keep premiums stable. At the same time, awareness of the marketplaces and the financial assistance that many people are eligible for it remains low. We're finding that enrollment of those key features is still low even after many years. That's particularly true among the uninsured. We're also seeing that enrollment of new consumers who tend to be younger and healthier is down. Enrollment of new consumers has dropped by about 50% since 2016 alone. According to one estimate, there are at least 2.3 million fewer new enrollees that would otherwise be in the marketplace due solely to cuts to outreach and advertising. In closing, most people are healthy most of the time, but everyone eventually gets sick and needs access to comprehensive health insurance. The actions discussed today do nothing to advance high-quality, affordable health insurance. Instead, these actions divide the risk pool between the healthy and sick and increase premiums for people with pre-existing conditions. Thank you again for inviting me. It's an honor and privilege to be here, and I look forward to your questions.
Thank you, Professor Keith. I now would like to recognize Ms. Jessica Altman, again, the Commissioner from Pennsylvania Insurance Department. You have, you're recognized to present your testimony to us.
Thank you, and good morning, Chairwoman Eshoo, Ranking Member Burgess, and members of the Health Subcommittee. As mentioned, my name is Jessica Altman, and I am privileged to serve as Insurance Commissioner for the Commonwealth of Pennsylvania. I want to thank you for convening today's important discussion regarding short-term plans and for the opportunity to voice concerns about the potential harms for consumers and for the health insurance market more broadly. As the name says, short-term plans were created to fill brief gaps in coverage. The plans generally have lower premiums, but significant coverage limitations, as the protections of the Affordable Care Act, which I'll call ACA, do not apply. By recently extending the duration and renewability of short-term plans, the federal administration is seeking to make short-term plans look and act like a viable alternative to comprehensive major medical insurance without extending the protections of the ACA. Today, I will highlight my 4 primary concerns illustrated by actual consumer complaints and conclude by sharing with you a little bit about my department's approach to short-term plans. Please reference my testimony for a more thorough perspective. The first primary concern with the plans that I raised today is one Katie covered well. They have very limited benefits and consumer protections. Short-term plans do not have to cover essential health benefits, and in Philadelphia, the same study Katie mentioned found that less than 60% covered mental health, only 1/3 in the midst of the opioid crisis that is hitting Pennsylvania very hard covered substance use disorder treatment or prescription drugs, and none covered maternity. Short-term plans can impose lifetime and annual limits on coverage, do not include appeal rights, and are not subject to a medical loss ratio requirement that sets a floor for the percent of premium spent on actual medical care. Instead, for the two short-term insurers with 80% market share, less than 50 cents of every dollar collected in premium was spent on actual medical care. Recently, my department worked with a woman who fainted at work and hit her head, something that could happen to any of us, and it resulted in emergency transport to the hospital. The short-term plan paid $200 for the ambulance, leaving the patient with $1,250. At the ER, the plan provided $250, while the bill was over $2,400. Then she was admitted to the ICU, where the benefit was again $1,250 for a bill that was $9,300. Finally, the plan paid another $1,250 for an outpatient test, while the bill was $4,900. After considering cost sharing, the plan covered just over $1,300. The consumer, $16,000. My second concern is the lack of consumer disclosure regarding benefits and benefit exclusions. The plans are sold without a consumer's access to provider directories, formularies, sample coverage documents, summaries of benefits and coverage, and a uniform glossary, all of which are required to be provided with Affordable Care Act plans. The lack of consumer disclosure is so troubling in the short-term market that we are creating our own consumer awareness campaign to try to cut through the noise of robocalls, well-placed online advertising, misleading website URLs, and a lot of fine print that are currently bombarding consumers across the country to purchase these plans. A recent study found that consumers shopping online for health insurance, including those using search terms like Obamacare or Enroll ACA, will most often be directed to websites and brokers selling short-term plans or other non-ACA compliant coverage. And this is, of course, exacerbated by the lack of comprehensive ACA information, outreach, and enrollment. The third issue is claims practices. I am most concerned by the use of a practice called post-claims underwriting, which often results in a rescission or denial of coverage. As short-term plans often exclude coverage for pre-existing conditions, policyholders who get sick may be investigated by the insurer to determine whether the recently diagnosed condition could be considered pre-existing and therefore excluded. We are currently working with a consumer who purchased a short-term plan and was diagnosed with heart failure. After he filed a claim for services, he was denied coverage based on the pre-existing condition. But he had never been diagnosed, never sought, and never received care for his heart. But instead, the insurer indicated that the claim manifested in such a way that an ordinary prudent individual would have sought medical treatment and advice in the year prior to purchasing the plan. Through the course of working to resolve consumer complaints, the claims practices of short-term plans have repeatedly demonstrated an inclination to deny coverage rather than provide it. Lastly, and I see my time ticking down, so I'll be quick, encouraging the proliferation of short-term plans has the potential to destabilize and drive up costs for the ACA market, especially for those with pre-existing conditions, by segmenting healthier people out of the market. The federal government does also continue to push for the proliferation of short-term plans through regulatory action, such as the 1332 guidance. And a waiver like that under the new guidance would not be one that Pennsylvania would pursue. Thank you. I will shorten my remarks and welcome any of your questions.
Thank you very much. It's my understanding that Ms. Altman was an intern with Mr. Waxman of the Energy and Commerce Committee. So congratulations on your climb.
Thank you.
And your great foundational learning here at our committee. And of course, thank you for your testimony. Now, I'd like to recognize Ms. Grace Marie Turner. You're recognized for 5 minutes, and welcome, and we look forward to hearing your testimony.
Thank you, Chairwoman Issue. Thank you, Minority Ranking Minority Member Burgess and members of the committee for inviting me to testify today. I'm with the Galen Institute, a nonprofit organization focusing on ways to ensure access to affordable health coverage for all Americans. Enrollment in the individual health insurance market is falling. In 2018, 3 million fewer people had individual coverage than in 2015. The primary concern is the cost of coverage. The administration's new 1332 guidance is designed to allow states to repurpose some ACA money and improve their markets to help those shut out because of high costs. 8 states have so far created programs to separately subsidize patients with the highest health care costs, lowering premiums and leading to increased enrollment. In addition to Alaska and Oregon, Maryland is seeing huge price drops of 43% net this year. Putting the sickest people in the same pool with others, as the ACA does, means premiums are higher, often much higher than for those without subsidies. Virginia State Senator Bryce Reeves told us of an email he received from a constituent in Fredericksburg who makes a good living and tried to provide for his family, but said his insurance premiums now cost $4,000 a month. That's more than my mortgage, he told Senator Reeves, asking what he's supposed to do. Cost relief is essential. The Trump administration last year did finalize rules to expand access to temporary bridge policies, short-term limited duration plans. These policies help people with gaps in employment, early retirees waiting to qualify for Medicare, young people in the gig economy, people returning to school, and entrepreneurs starting new businesses. These short-term plans typically cost less than half of the cost of ACA plans. Under the Obama administration's previous rule, people would lose their short-term plans after just 3 months, even if they acquired a medical condition within that period. By extending the contract period to a year, people can be protected and have coverage until the next ACA open enrollment period. While consumers do need to be informed about these plans, for many, they may mean the difference between having the security of coverage for a major medical event and being uninsured. The Council of Economic Advisors issued a report just last week estimating that these policies produce an economic benefit of $80 billion over the next 10 years. I'd like to turn to pre-existing conditions. There's a strong bipartisan support for these protections, as Mr. Walden and Dr. Burgess both have ensured. The ACA assures that people cannot be turned down or have their policies canceled because of their health status, and these protections remain in place. People with chronic conditions are vulnerable and do need protection, but a woman with a serious health problem provided us with a testimonial about why more changes are needed. Janet reports that in 1999, she was diagnosed with hepatitis C. She lives in Colorado and applied for coverage in the state's high-risk pool and was accepted. Her premiums by 2010 were $275 a month. Then her liver failed. She needed a transplant. The $600,000 bill was covered 100% with $2,500 out of pocket. Colorado's high-risk pool, however, was closed when the ACA took effect, so she moved into the marketplace. Her premiums rose to $450, and by 2018, they were $1,100 a month with a deductible of $6,300. She said those of us who are self-employed but make more than the threshold of tax credits wind up footing the whole bill ourselves. Finally, regarding navigators, legislation proposed by Representative Blunt Rochester would provide $100 million a year for the Navigator program, but CMS found that in 2016, 78% of navigators failed to achieve their enrollment goals. And navigators enrolled fewer than 1% of enrollees while spending $62 million that year. CMS now funds navigators based upon their ability to meet their enrollment goals and during the previous year and relies more on brokers and insurance agents who enrolled 42% of enrollees. California spent heavily on marketing last fall to increase enrollment in its state exchange, yet it experienced a 24% drop in new enrollees. Marketing doesn't work when the main reason that people don't sign up for coverage is because of cost. I would welcome the opportunity to work with you in developing new ways to help lower the cost of health coverage while maintaining quality and consumer protections, including pre-existing condition protections. Thank you, Madam Chairman.
Thank you, Ms. Turner, for your testimony, and we've now concluded the opening statements. We're going to move to members' questions, and I'll start by recognizing myself for 5 minutes. I have a lot of things in front of me that have been suggested that I ask, but after listening to your verbal testimony, I want to mix this up a little bit. We heard the first two witnesses, Ms. Keith and Ms. Altman, talk about the shortcomings of these short-term plans and the plan of the administration to stretch them out over 3 years. Now, Ms. Turner, you said we have a commitment to pre-existing conditions in the coverage. Why is it not included in these short-term plans? I'd also like to give 30 seconds to Ms. Keith and Ms. Altman to ask any question that they'd like of Ms. Turner, because there's a difference between your testimony and Ms. Turner's. But first, can you talk about what, I think the word commitment is conflated in its use. There's a difference between a commitment to and actually practicing what you say you have a commitment to. So I don't see these very important insurance reforms that we brought about with the ACA, and you saying that you have a commitment to pre-existing conditions and the other insurance reforms. So can you just, in a minute or less, explain why there's a difference between your commitment and what's in these plans?
Short-term plans are really gap coverage. People buy them because they can't afford coverage that has all of the ACA protections.
Let me ask you this. Are you opposed to an advisory in plain English on the cover of these policies to inform the potential consumer what is not included, so that it's very clear about what they're buying?
Absolutely. I think
Okay.
consumers very, very much need to be
Good,
informed about
good.
the policy.
All right, now, Ms. Keith, you want to ask a question or have a comment?
Yeah, I don't have a question. Thank you, Chairwoman. What I would say, something that did not get brought up in my oral statement yet, is that the limitations of these plans, there's no magic about why these short-term plans are cheaper than ACA plans. They're on average about 54% less expensive. There's no secret to that. The reason is because they can exclude people with pre-existing conditions. That fact alone allows them to be 38% cheaper than ACA plans. When you add in some of the benefit gaps and out-of-pocket costs, that's what makes them half the cost of ACA plans. And so the idea of giving people coverage, is the product worth buying if it doesn't cover anything when you need to use it, I think might be the question.
Ms. Altman?
I was going to bring up the same study, and to put it another way, 70% of the price difference between short-term plans and traditional ACA plans is due to pre-existing condition exclusions. The story you told.
Can you say that again?
70% of the difference in price between short-term plans and Affordable Care Act coverage is due to excluding pre-existing conditions. The story you told from Colorado was incredibly compelling, and to me it really reinforces why people need comprehensive coverage, so that you can get coverage for that expensive transplant and you can get coverage for your liver failure and your hepatitis C. My only question is, today you talked about how the purpose of short-term plans is to fill gaps in coverage, and that is the intended purpose. And I suppose my question is, if it's meant to fill a gap, why would it need to be 3 years?
Can you answer that, Ms. Turner?
I think that that's really up to consumers. Many of the people who are uninsured now, many of the 3 million are uninsured because they simply can't afford coverage. State Senator Reed's constituent desperately wants us to provide for his family until another option is better. So he can't know how long he's going to need to have this protection. One of the reasons that the new rule extended that coverage is because 3 months just is too short a time to give anybody the security that they need coverage. And in Colorado, Janet is actually now in an ACA plan. Her meds are not covered under the plan that she's in under the ACA. So she
Well, I think, if I might say this, I think it's important for consumers to have choice. I'm not opposed to that. What I'm worried about is I've found this out in healthcare. The two basic things. Everyone knows what they pay in a premium. Most people don't know what they're buying, what they're getting. And this can be a really slippery slope for a lot of people, and or maybe for a few that's going to make them, especially if they're healthy and they're young, they're betting on their immortality and that nothing's ever going to happen to them. But it is, there are a lot of questions. So thank you. My time has certainly expired. I now would like to recognize Mr. Griffith for his 5 minutes of questioning.
Thank you, ma'am. Right here beside you.
Right, sitting right next to me.
I am glad to hear, Madam Chair, that you're for consumers having choices. I think that's very important. I also look forward to working with you on your bill, 1147, I believe, that deals with making sure that consumers have the information that they need. I would say, as we work forward on that piece of legislation, it looks to me right now that it includes such a huge volume that many consumers probably wouldn't read it. So what we have to do is try to figure out where the sweet spot is, and I look forward to working with you on that, because I do think it's important that consumers know if they're buying an alternative product, that A, it is an alternative product, and B, that it doesn't cover everything, but here's what it does cover. Because as you pointed out, Ms. Turner, many folks are looking for something because they cannot afford the plans that fall under the ACA with all the mandates that are there. Could you repeat the quote from Senator Bryce Reeves? Since I'm from Virginia, while his district is about 4 hours away, I do think it's instructive to hear from him again. Could you repeat that for us?
Yes, Senator Reeves was at an event, speaking at an event, and had just gotten an email from a constituent saying that he had just received his health care bill to provide for his family, and the premium was $4,000 a month, which he said is more than my mortgage. What am I supposed to do?
Yeah. We hear stories similar to that 4 hours away on the other side of Virginia. I represent the southwest portion of the state. We hear of a lot of people who can't afford the out-of-pockets and the deductibles, that's forcing them to look at bankruptcy options. The same complaints we heard before that the Affordable Care Act was supposed to fix hasn't worked for my constituents. It clearly hasn't worked on the other side of the Commonwealth of Virginia. I can't speak to the country as a whole, but from anecdotal evidence, it seems that the same is out there. And as you pointed out in your testimony, this is one of the reasons why people are looking at some of these alternatives. I think they ought to know what they're getting, because some people will just buy something because it's cheaper, but some people buy something that doesn't cover everything because they're desperate. Is that true?
That's true, and unfortunately, in many parts of the country, and especially Virginia, if you live in one county, you may not have a choice. This constituent had no other choice in Fredericksburg, and so people are looking exactly for that, to find other ways they can have health insurance they can afford, protect their families, but not be able to pay their mortgage.
It's interesting that you raised that point about the choice, because under the ACA, I represent 29 different geopolitical subdivisions, and for those that aren't from Virginia, we have separate cities. So some of those are small cities as well as counties, but I have 29. A fair number of those have but one provider. They just the market is just not there to support it. I'm surprised that that's the case in the Fredericksburg area, because that's a much bigger area population-wise than some of my jurisdictions. But you're saying they had that problem too? There was just one provider?
Yes, and I would
Of
hope
insurance.
that
Yeah.
Virginia would look at the Section 1332 waivers to figure out how they can attract more competitors back into the markets.
And I would hope that that would be the case too. Let's talk about the woman you spoke of, Janet, with hepatitis C. Could you go over the numbers again of how much she was paying under the plan that resembled what the House was trying to do last year, or 2 years ago now, to do our repeal and replace? With the high-risk pool, she was only paying $275, I think you said, a month for her insurance?
When she was first diagnosed with hepatitis C in 1999, her premiums in the state's high-risk pool were $275 a month. And then they rose when she had to first enroll. That high-risk pool was closed.
But hang on, but before that high-risk pool was closed, you indicated she had to have a liver transplant?
She had to have, her liver failed, and she had to have a $600,000 liver transplant.
And that was covered?
Totally covered by the high-risk pool. She had $2,500 out of pocket. But then when the ACA took effect, her premiums rose to $450, and by 2018, they were $1,100 a month. And one of the things I didn't mention in my testimony is that none of her anti-rejection drugs are covered under the new plan, so she has to pay out of pocket $19,000 a year.
Wow. Plus, there was a $6,300 deductible, I think you mentioned.
Correct.
And so what you're saying is that this high-risk pool, which was an alternative before the ACA, was an alternative to the ACA, which would work for some people, and we should probably have more choice. Wouldn't you agree, yes or no?
She said yes, and she said, I want the high-risk pool back.
All right. I thank you very much, and I yield back.
Thank you, Mr. Griffith.
Thank the gentleman. I'll now recognize the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Madam Chair. And I just, want to reiterate that, of course, in my opinion, the problems that we face with, more people becoming uninsured and increased costs are directly related to the sabotage that the Trump administration has implemented. And that's why we're having this hearing and trying to deal with these issues, with the sabotage, and coming up with legislation that would turn that around. But I wanted to talk about the 1332, Section 1332 of the ACA. Ms. Turner, my questions are of Ms. Keith, but Ms. Turner's testimony appears to conflate the October 2018 Trump guidance with the Section 1332 reinsurance waivers that were approved both under Obama initially and then now under Trump. So, Ms. Keith, can you walk us through the Section 1332 reinsurance waivers? Those are the ones that, were initially under Obama, now under Trump. What are they, and how long have they been in existence? And have those reinsurance waivers been successful in reducing premiums in the states where they've been enacted, including my own, I guess?
Thank you, Chairman. Yes, so a number of states, 7 of the 8 states with an approved Section 1332 waiver now have done that for a state-based reinsurance program. I think this is evidence that Section 1332, as is working. Congressman Griffith mentioned this, Ms. Turner has mentioned this. Using those Section 1332 waivers that we already have, the federal government has passed through about almost $1 billion in federal funds to help states come up with these solutions that have brought down premiums ranging from 7% at the low end to more than 30% at the high end. And more states, I would expect, are considering that this year to bring those programs to their states as well. There's certainly been bipartisan support, as you can tell, from states ranging from Wisconsin to Maryland to Oregon to Alaska.
And I agree with you, and certainly my state is an example of what you said. But now I want to turn to the Trump administration's recent 1332 guidance, which it issued in October of 2018. And these are entirely unrelated to the reinsurance waivers you just discussed. The Trump administration's recent 1332 guidance creates new standards that are wholly inconsistent, in my opinion, with congressional intent. And the Trump guidance would allow states to increase consumer costs, reduce coverage, and undermine protections for people living with pre-existing conditions. In other words, more Trump sabotage. So, Ms. Keith, do you believe that the new Trump changes to the guidance are consistent with the law and the clear statutory directive that states must provide coverage that is as comprehensive and affordable as under the ACA?
Thank you for that question. In my opinion, I think the guidance is quite inconsistent with Section 1332 itself. Section 1332 absolutely gives states the flexibility to be innovative, but it directs them to do so in a way that builds upon the ACA and is consistent with the goals of the law, which is to improve access to affordable quality coverage, not to undermine it. The guidance itself, by allowing or at least encouraging states to consider options like subsidizing short-term plans, plans that do not cover pre-existing conditions, as we've discussed, to me, flies in the face of Section 1332 and what it was designed to allow states to do.
All right, now I just want to have you repeat what you said with regard to junk plans specifically. I understand that the Trump guidance would allow states to redefine what counts as coverage to include junk plans. Is that correct?
It encourages states to bring forth proposals that would allow that, yes.
And then do you believe, obviously you said you don't believe that this new definition of coverage is consistent with the law, correct?
That's right.
And then I also understand that the guidance allows states to direct the ACA's affordability subsidies towards junk plans. So subsidizing junk plans. Do you think that's consistent with the law?
I do not. Section 1332 cannot be used to waive any and all provisions of the Affordable Care Act. In particular, it cannot be used to allow states to waive community rating, guaranteed issue, protections for pre-existing conditions. If a state were to try to subsidize plans that did do that, I think it would be an end run around Section 1332 itself and what the law requires.
All right, thank you, and I agree with you. I think that the Trump administration's guidance is blatantly unlawful, contrary to the plain reading of the statute and wholly inconsistent with congressional intent. It's part of the Trump administration's ideologically motivated efforts to sabotage Americans' health care coverage. And I want to commend Ms. Custer for her work on this important legislation to rescind this guidance and hope that our Republican colleagues will join us in these efforts. And I just wanted to say, Madam Chair, you know, most of the sabotage that the Trump administration is doing, in my opinion, is totally illegal. So you might say, well, then why are we trying to move and having hearings on legislation if you don't think it's legal to begin with? Well, I guess that's a good question. But the bottom line is that we're going to do it because we've got to make the point that, you know, that their interpretation, the Trump administration interpretation of the law is to allow all this stuff that sabotage the ACA. So we're going to come back and say, you know, that's not allowed under the law, but we're still going to clarify it by moving forward with legislation that would make that clear and improve it. Thank you.
Thank the chairman of the full committee. And now I'd like to recognize the gentleman from Kentucky, Mr. Guthrie, for 5 minutes.
Thank you, Madam Chair. I really appreciate it, and I appreciate all of you being here. And I want to start by what I heard from Dr. Burgess and echo some of his opening remarks on the cost of plans and talk about how it affects people outside of being subsidized, that as just looking for alternatives to have coverage because they can't afford. You may have all the mandates and all the guaranteed issues, but if they can't afford it, they can't afford it. And particularly, I've had a constituent named Dustin Jones, who's a resident of Glasgow, Kentucky, who's called and said he had the coverage that he liked before the Affordable Care Act. Now he's going to have to go uninsured because he says he's just at the point he can't afford insurance anymore. And so I'll be honest, I've had people stop me and say because of Medicaid expansion in Kentucky, they've had coverage they haven't had before. So there are people, everybody can point to cases such as that. But I think all of us have people like Mr. Jones that are in that middle income area that health insurance has just become unaffordable because so many of the mandates that are there. And we want to cover people with pre-existing conditions, and we need to do it in a way that's affordable. I think Ms. Altman said that plans are 70% cheaper because they don't do pre-existing conditions. So I guess that inverse, say it's be 70% more expensive because, and that's what we wanted to do in the Affordable Care Act replace that we looked at. They got highly criticized, but it was examples. I think Wisconsin had a highly functioning high-risk pool, and people said they were better off before, where you socialize the costs of pre-existing conditions across the state instead of just people in the individual market, because it puts people like Mr. Jones out of being able to afford health insurance. And so the bottom line with that, everybody was covered pre-existing conditions. It was just a way to do it that didn't put the burden on just people in the individual market. It socialized those costs across the state. But Ms. Turner, in your testimony, you mentioned the additional consumer protection that the Trump administration added for short-term limited duration plans. Just give you an open to explain that further, the additional consumer protections that the Trump administration added.
You mean in terms of allowing people to keep these policies for a longer period of time? That they previously, under the Obama administration, were limited to just 3 months. And for many people who may be retiring at age 63 or 64, and they need gap coverage until they qualify for Medicare, people who are starting a new company, people between jobs. That just wasn't long enough, and being able to give them the opportunity to purchase these short-term bridge policies was very helpful. And I agree that people need to be informed consumers, but I think they do understand this is not permanent coverage. This is to fill a need in a particular time for an estimated 2 million people.
So it's not only is the Trump administration giving patients more health care products to choose from, they're doing so in a way that has additional consumer protections. So I just want to also, Ms. Turner, you mentioned how states are working within the 1332 waiver to innovate as laboratories of democracy. We've already seen 8 states get approved under the strict Obama administration guidance. Do you anticipate even more innovation as states review and reform their markets in compliance with the Trump administration policies?
The states are doing, yes, absolutely, and the states are doing everything they can to try to, under the ACA, to try to provide access for people who are shut out of the market. These are people in the individual market who generally don't qualify for the subsidies under the ACA, trying to afford health insurance for their family, like Senator Reeves' constituent in Fredericksburg, to try to provide a policy that they can afford. And there are other provisions that the administration is providing as well. The association health plans, so small companies can aggregate to get some of the benefits and the lower costs of larger companies. The new health reimbursement arrangement rule that would allow companies to provide a stipend to employees that may have the opportunity to get coverage outside the market, maybe a spouse's coverage, and be able to buy into that policy to get a family plan. So they're really looking for ways to give people more options and to give states more options to use the existing ACA money in a way that works better for their citizens.
Okay, thank you very much. Just one more example, a person who does transmission work on cars. Hopefully you never have to do that, but if you do, that I use and been to, is a single person shop, and he runs his own shop. And he told me that it was about 6 months ago that he doesn't open till like 9, and then he closes from 3 to 5, and then he comes back and does it in the evening. And what he's doing, he's driving a school bus to pay for his health insurance. And he said by the fact that he went to work for the county system driving a school bus, by the time he does all of his premiums, he really doesn't make any money doing it. But he said, but I'm making $1,600 a month because that's what was saving in my health insurance. So there are people really struggling with this, and we need to be mindful of the Affordable Care Act didn't solve everybody's problem. So thank you very much, and I yield back my time.
Congressman.
I thank the gentleman from Kentucky. Now I'm pleased to recognize the gentlewoman from California, Ms. Matsui.
Thank you very much, Madam Chair, and I want to thank the witnesses for being here today. It's been very enlightening and interesting here. The topic of this hearing is incredibly important to me and my constituents, and actually all Americans whose lives have been changed by the Affordable Care Act. Just last week, this committee heard testimony from families whose lives have been fundamentally changed by the protections of the ACA. And that brings us to today's discussion, and very sadly, the sabotage of the Trump administration disguised in a disingenuous attempt to expand coverage is shameful. This administration has done nothing to expand coverage. Rather, they have undermined the progress made by the ACA, leading to further market destabilization and harming patients along the way. Now, these junk insurance plans sound good. However, they discriminate against people with pre-existing conditions and set higher premiums based on age, gender, and health status. Promoting the use of junk insurance plans is particularly frustrating when this administration has also slashed outreach funding for open enrollment and the health care marketplaces. Expanding junk insurance will undermine the market, taking young, healthy individuals out of the risk pool and making health insurance less affordable for consumers with pre-existing conditions. The Trump administration has even acknowledged that the new rule would raise premiums for ACA-compliant plans and could result in adverse selection against the individual market risk pool. Ms. Altman, according to the Kaiser Family Foundation, if an individual loses coverage under a short-term policy, then they may not be eligible for a special enrollment period under the ACA. In other words, the individual would experience a lapse in coverage. Given this information, I'm concerned that these junk insurance plans could put many more individuals at risk. Could you reiterate to the committee how, before the implementation of the ACA, how a lapse in insurance coverage impacted your financial situation and physical health?
Certainly, I think before the ACA, lack of insurance coverage or lack of comprehensive insurance coverage impacted people in the same way that it could today. Their inability to seek the care that they need, their inability to afford the care that they need, and potentially financial devastating debt. I think one of the perhaps less talked about benefits of the Affordable Care Act has been reductions in Americans going into debt due to medical bills, and the reductions in uncompensated care and the burden that is on the economy and on our healthcare system as well.
Right. Could I just say this too? Now, I hear from my constituents, both patients and physicians, who are frustrated they're receiving high, unexpected medical bills. And part of this is because they're enrolled in a junk insurance plan, like we're discussing today, that have an incredibly high deductible. A $10,000 deductible doesn't count as real insurance. If you have to spend $10,000 out of your pocket before your insurance kicks in, what does that really buy you? And shouldn't consumers fully understand what they're signing up for? Now, Ms. Altman, your testimony, you told me about this. What steps does your department take to alert consumers to the fine print of these plans?
Thank you for that question. One of the greatest challenges with these plans is trying to counter all of the noise in the marketplace. A lot of the marketing is very aggressive. Some of it is outright untrue, and some of it is in a gray area and misleading at best. We have undergone a number of efforts to try and get accurate education out in the marketplace, accurate information about short-term plans, about the Affordable Care Act, about the difference, about when to enroll, all of those questions. But it is definitely an uphill battle as consumers are being bombarded with the marketing that is out there. We are now working on our own campaign that will highlight the questions consumers should be asking themselves and try to be proactive in getting that level of information out in the marketplace.
And shouldn't CMS be a part of this, in essence, to educate the public about all the plans, in essence, junk plans included, about what they include or do not include? And I've just got a short question here. I think it was brought up, the extension of the plan to 3 years, they said, actually helps consumers. How could it help consumers if they can be kicked off the plan at any time? Ms. Keith?
Sure. Thank you for that question. I do think that's the right question. How is being in a plan for a longer period of time that offers what can sometimes be illusory coverage? So the idea that these plans are offering coverage but can at any time exclude coverage because of a pre-existing condition or engage in post-claims underwriting. The idea of extending those plans when the coverage may not be there when the person really needs it, I wouldn't call that a consumer protection.
Thank you. I've run out of time. I yield back.
Thanks, the gentlewoman. Now I'd like to recognize the gentleman from Illinois, Mr. Shimkus, for 5 minutes.
Thank you, Madam. Thank you, Madam Chairman. When my colleague from California was talking about that plan, I thought she was talking about a Obamacare plan. In March 26, 18, I got this email from Miss Penny from Centralia, who said, "We are a small company that employs 5 people. We just received our new health insurance premiums for 2018 with a rate increase of $650 per month." That was an increase of $650 per month, and a higher deductible ranging from $3,200 to $4,000. Nothing has been done to resolve the health, and then she just complains about being forced to buy an insurance product that she can't use. And in rural America, we heard this quite a bit. Small businesses forced to buy insurance they can't use because they can't use it, costs so much, and then the deductible is so high that they're not covered. So that's why this is a really important discussion. I'm also glad following my colleagues. I was up at a telecom or down at a telecom hearing. So I missed some of this debate, but it sounds like we're talking about quote-unquote junk plans. So what are these junk plans? Well, we'll see. The Trump administration has permitted workers and small businesses to pull together to buy insurance known as associated health plans. I've always been a supporter of that. Farm Bureau, Manufacturing Association, Chamber of Commerce, bigger pools, negotiating. Obviously, my colleagues call all these junk plans, even though most of these so-called junk plans comply with ACA mandates. They aren't charging people different premiums based upon health conditions, and they're not banning people with pre-existing conditions from enrolling. So, Ms. Turner, do you think labeling associated health plans as junk is a fair description for coverage that many hardworking Americans seek out and choose to buy for their family?
I'm very supportive of giving small companies in particular more options for health insurance, which is what association health plans do. And individuals also need other options, which is what the short-term limited duration plans provide. There was a study recently, I think just last week, about association health plans, and they were in fact providing coverage as comprehensive as larger companies, and they were not excluding people for pre-existing conditions.
I think one of the things that fired us up so much about this debate was the debate of who is to determine what policies we have. When we thought this was going to go to the Supreme Court, we thought it would stand on the inability of the national government to tell you what you had to buy. In fact, when this was debated here in the halls of Congress, that was the arguing point. We said, this is not constitutional. Then the administration fought for the constitutionality based upon not the right of the individual to make a choice of what they want to buy, but on the right to tax. So that's why it was upheld, not on the individuals being forced to buy something, especially my constituents who are being forced to buy something that they can't use, as Ms. Penny has highlighted here, and she's trying to provide for her employees, and she can't do it. So the employees across the country are already taking advantage of this option to provide more affordable insurance to their workers. In fact, 28 AHPs have formed already, with some showing up to 30% savings on premiums. The Las Vegas Chamber of Commerce is in the process of signing up 500 employees for an AHP, which could save some employees more than $2,000 per year. Ms. Turner, do you, again, if these plans are junk, why are they so attractive to business owners and their employees?
People are just desperate for choices. They feel shut out of the market not only because of the premiums under the comprehensive coverage under the ACA, but also because of the deductibles, which can be $10,000 a year in the ACA plans. And so people are looking for other options, short-term limited duration plans for bridge coverage, and other ways to get economies of scale through association health plans, and letting states have more power through their 1332 options.
Yeah, and I'll end on this. I appreciate it. We Republicans believe in markets and competition, not centralized control dictates from the national government authority. And that's why I'm glad we're having this hearing today, and I look forward to more discussions. And with that, Madam Chairman, I yield back my time.
I thank the gentleman. Just for the record, this hearing is not about association health plans. We're talking about the short term, what they cover, what they don't. And so I think it would be wise to stay away from conflating things and putting words in other people's mouths that they haven't uttered.
Will the gentlelady yield?
No, I want to move on. No, because this hearing is on these short-term plans, not on association health plans. So
you appreciate associated health plans? Is that?
I do,
Okay, very good.
except for what the administration is doing to some of them. We can have a hearing on that, but today's hearing is not about association health plans. I now would like to recognize the gentlewoman from Florida, valuable member of our committee, always, Ms. Castor, for 5 minutes of questioning.
Well, thank you, Madam Chair. Thank you for holding this very important hearing on our legislation to address the Trump administration's sabotage on affordable health care for our families back home, including my bill, H.R. 1010, that will stop the expansion of these junk health insurance plans. See, working families across America, they remember well the attempt by the Trump administration and Republicans in Congress to repeal the ACA in its entirety, including the protection on pre-existing conditions. What the Republican Congress was not able to accomplish here, they are now trying to accomplish through administrative rule. And that's where they have now adopted an administrative rule that would expand the use of these junk insurance plans that do allow discrimination for if you have a pre-existing condition like a cancer diagnosis or diabetes or asthma or something like that. These junk plans also deny basic health benefits. So that's why I filed H.R. 1010 along with my colleagues, Congresswoman Berrigan, and other members to address these plans that really don't protect our neighbors as they should. It really is difficult to understand why the administration is promoting plans that do not provide adequate coverage. It really appears to be a cynical ploy to lure families into these plans that were too prevalent before the Affordable Care Act. Where benefits were excluded and families faced massive health care bills. I am very concerned that the public is being snookered here. And Commissioner Altman, I'd like to ask you a few questions about this, about these junk plans. I understand that these plans often impose lifetime and annual limits on care. Is that right?
That's correct.
So can you describe what these plans typically look like, how they're marketed, what kind of coverage they provide?
Sure. I think to the average consumer, the plans can look like they cover a lot of things. They have coverage for hospitalization, coverage for ambulance transport, coverage for doctor's visits, some of those things. But when you begin to look beneath that, first of all, there are many exclusions, both in terms of certain benefit categories like mental health and prescription drugs and maternity, but also for any care related to a pre-existing condition, whether determined before the plan was issued or after, exclusions for any injury that results from sports activities or other risky activities, things like that. Then you have cost sharing, high deductibles, co-payments, co-insurance. Then you have annual limits on coverage, potentially lifetime limits on coverage, although as a short-term plan, it is unlikely someone would be able to retain this plan for a lifetime. And then you get into what they actually cover within those categories of benefits. I think the story I shared in my testimony is very indicative of the fact that the coverage levels are not reflective of the cost of services. So a consumer may see it covers $100 or $200 for an ambulance ride, and that may sound reasonable to them and like coverage, but of course we know an ambulance ride generally costs well over $1,000.
So then they're stuck paying that.
Correct.
Bill, unlike an Affordable Care Act policy. So we've heard a lot of discussion about choice here today, and choice is important. And under the Affordable Care Act individual market policies in your state, I read in the testimony you actually had another insurer come into the marketplace. Is there adequate choice among those policies that are being offered in Pennsylvania right now?
That's correct. We've put in a lot of work to get our individual market in a very good place. I approve statewide average decreases this year.
Wait. You've increased competition and choice in Pennsylvania is now lowering costs?
Correct. We have a new entrant. 30 of Pennsylvania's 67 counties had more insurers offering coverage this past year compared to the year before. And we reduced our single carrier counties from 20 to 10 simply by working to make the market a place.
But if we had more junk health plans, it would seem that that would be a false choice for folks because they'd be on the hook for substantial cost. Is that right? Do you agree
if they
with that?
chose that route, and of course for over 1 in 4 Pennsylvanians who have pre-existing conditions, those plans are no choice at all.
And I'd like to offer the groups that are now endorsing H.R. 1010, if folks are confused by some of the debate here today, here are some trusted organizations that now support the expansion of junk health plans: American Heart Association, American Lung Association, AARP, Cystic Fibrosis Foundation, March of Dimes, to name a few. Thank you, and I yield back.
Thank her for the legislation that she's offering. It's now my pleasure to recognize the ranking member of the full committee, Mr. Walden.
Good morning again.
Yes.
You must be torn as I am with the other hearing going on downstairs. I know your passion for telecommunications issues as well.
In fact, I'm going to ask Ms. Castor to come to this chair, take the gavel, and have you proceed.
Perfect. Thank you. Thank you, Madam Chair. And I want to thank our witnesses. This is really important issues for all of us to contemplate. And I know I met with some wheat growers from my district yesterday, as fate would have it, and guess what issue came up? It was the high cost of health care and health insurance, both the cost of individual items in the health care continuum, but also the health insurance. And I'm trying to remember, I should have made a note on it, but I think one of the growers talked to me about how his rates per month had gone from like $300 to $600 to $900, and now it's like $1,000 a month for him and his wife. And the deductible, I'm going to say, was somewhere between $6,000 and $8,000. So to my friend's comment about the consumer picking up the difference in charge, there are a lot of consumers now, as a result of these enormously high deductibles you have to do to get a premium you might be able to afford, you're paying it out of pocket through your deductible. And so I think what I'm trying to get at, and Republicans are, is how do we have choices out there that fit families that they can afford that will actually give them first dollar, not first, but an affordable family dollar health insurance, and not something that amounts to something that's catastrophic. I do hope we do hearings on association health plans. I do think we have the right to talk about them in the context of this hearing, by the way. And I do hope we'll eventually hear from the majority, Democrats, about a hearing on Medicare for All, because we know by the estimates that would cost $3.2 trillion and do away with the health insurance that 150 plus million Americans have through their unions or their employers. And with the strength of the economy, more and more people are showing up on those plans and probably fewer on the others. And maybe, Mr. Turner, you could address this. My understanding is under the Obama administration, there was a 3-month period for short-term limited duration plans. The Trump administration simply said to states, you can go up to 12, but states have the right to step in here and regulate as they see fit, right? And is that correct?
Yes, absolutely.
And so there are some 33 states that have left the door open for this innovation to occur, correct?
Yes.
And so when you're looking at options people can afford that work for them, do these states, do these plans that are out there, do you think they give them options that work or not?
Consumers will determine that, and I absolutely agree that having state flexibility allows the states to, I mean, they're much better, frankly, at regulating local health insurance markets in their state than Washington can be, and really figuring out what do their consumers need, more information about these plans,
Right,
to make sure they're buying insurance that works for them and that they're smart, informed buyers.
Ms. Altman, I'm intrigued that the rates went down. Pennsylvania, correct? Is that right? So that's this year? Was that for all the plans?
In the individual market.
In the individual market? How much over the last 5 years?
That is the statewide average. Not all of the plans went down on their own, but on average, yes.
Over the last, say, 5 years, what's happened in terms of rates in Pennsylvania in the individual market on average?
Sure. There's no question that rates have gone up in this market. I think there
How
are.
much?
I don't know off the top of my head.
How much did they go up the year before?
So the year before they went up around 25 to 30%. But that's an important year because they should have gone up 6%. And in that year, the reason they did not was because of the decision to cease paying cost sharing reductions and uncertainty created by the
How much did they go up the year before that?
Around, I want to say, you're testing my memory, about 15% and about 8% the year before that.
So 8, 15, 20, what?
And then 20, and then -2.
And -2. So they went down, but they went down 2% after they'd gone up. I'm trying to remember that first year with the cost sharing deal. 25% they went up?
Sure, should have been
15 and 8. I'm a journalism major, so I'll let somebody else do the math. But the long and the short of it is consumers didn't get a $2,500 per year reduction in their premiums along the way, right?
Well, of course, 80% of consumers in that market receive financial assistance that largely shields them from those price
Correct.
increases.
And so my wheat grower friends that aren't eligible for that are small entrepreneurs. They've gotten socked with rate increases. They don't get the subsidies. They're the kind of working middle class folks that are just off the subsidy side because they're just at that realm. I had a town hall, one 2 years ago in Arlington, Oregon, and actually we had this debate there, and this farmer got up and talked about what his family had faced. And this person who was very much in support of the ACA, Obamacare, went up to him afterward and said, "I didn't know people like you existed." And he was very serious about it. So we have this gap out there that some of us are trying to figure out a way to fill. And that's what Republicans are talking about. How do we fill that gap for those people that don't get the subsidies you get on the exchange if you're right income, but you're still left out with a high deductible and premiums off the charts? My time's expired, Madam Chair. Thank you for your indulgence.
Thank you. Mr. Schrader is recognized for 5 minutes.
Thank you, Madam Chair, and I appreciate the previous gentleman's discussion, the ranking member of the committee. And there's been a lot of discussion about the cost of the premiums, the deductibles in the individual marketplace. I think it's important for America and a lot of people here to understand that that's only one facet of the Affordable Care Act. And the rest of the Affordable Care Act ostensibly is working very well. We heard last Congress with the repeal and replace debate that, frankly, a lot of red state people were very pleased that the Medicaid situation changed dramatically for them. Many millions of Americans had health care for the first time. So I guess I'd like to look to my colleagues and say, hey, let's work on the individual marketplace. I'm fine with that. I think there's an opportunity for us to work together and maybe adjust the cost-sharing stuff, the reinsurance issues, or risk pools, and maybe expand the 1332 waivers. But under constraints. You know, people forget, I come from Oregon, people forget that the goal of healthcare is to provide better health. It's not to get insurance. And ostensibly getting better health means you don't have to read the fine print all the time. There's some commonality in these plans that are out there, and you have the opportunity to buy a product that covers what people would call essential health benefits, that overall, if someone had a mother, someone's got a daughter out there, I mean, you know, being a woman and having maternity care should be an option. I mean, everyone benefits from that over the long haul. And the goal of insurance to provide health care is to prevent people from getting too sick to begin with. And that has gotten lost, I think, in a lot of the debate. So I'm hoping that we actually get to that. Ms. Turner, real quickly, you know, with these short-term plans and the expansion of the short-term plans, how do you actually justify that when the rules of the road clearly state that the waivers that are granted under 1332 are only supposed to be for those plans that provide coverage that's at least as comprehensive as the coverage under the exchanges, and that the coverage and cost-sharing protections are as affordable. In other words, they go together. Again, getting at the fact that the undermining of these essential benefits, I think, is disingenuous to a lot of American consumers. What's the justification for doing that in these newer short-term plans the administration's put forward?
The administration spent, I think, about a year with a lot of career federal officials looking at this and how can you write the rule in a way that's compliant with the text of the ACA to make sure they're comprehensive, they don't increase the deficit, they're at least as affordable, to make sure that that would be allowed. So the rules would have to allow to make sure if people did buy a short-term plan that it fit these criteria. So all the short-term plans are not junk plans. In fact, I think very few of them are. Buyer beware. People need to be aware. They need to be informed. And there are protections if they are going to use a subsidy for these plans to make sure that they are compliant with the ACA.
Well, and I think you write the rules in the way you would like to write the rules, and I think that's challengeable, and we're going to see, I think, that reversed either in the courts or in this particular Congress. Ms. Altman, a lot of discussion about 1332 waivers and the ability for them to give states the opportunity to innovate. Totally agree with that. Oregon's been doing that for years. The Affordable Care Act really, I think, points that out as a great opportunity for states. I don't think there's any disagreement with that. And it's being done and has been done prior to this current administration very successfully, but it's been with these essential health benefits in play. And it hasn't been, I think, a curse or restrictive. Can you talk a little bit about the role those essential health benefits play in the waiver programs?
Sure. So essential health benefits are a set of 10 categories of core benefits that the Affordable Care Act was supposed to guarantee access to so that people with healthcare needs could have the benefits that they need to get the treatment they need regardless of the type of condition that they have. Those are what ensure that whether you have a mental health issue, a physical health issue, an emergency, or cancer, those benefits will be available, and they were intended through the guardrails in the ACA to be extended to any coverage offered through the 1332 waivers.
Thank you. And Ms. Keith, given the fact that ostensibly the Health and Human Services Department of the United States of America's goals to help Americans get quality, affordable health care, how do you think the current administration justifies curtailing the enrollment and outreach programs? That makes no sense to me.
I won't try to speak for them or on their behalf. My understanding is they think this is a more cost-efficient way, and that they believe that outreach and enrollment funding is not cost-effective. I would counter, there have been other examples from other states. Covered California is an example that attributes a decline in 6 to 8% of premiums just from the outreach and marketing work that they did to bring in healthy consumers. So it does certainly has been shown to help stabilize premiums.
Thank you very much, and I yield back.
Thank you. Mr. Long is recognized for 5 minutes.
Thank you, Madam Chairwoman. Ms. Turner, I'd like to talk about the roles that navigators and independent agents and brokers played. You note in the plan, you note that for the plan year 2017, navigators received more than $62 million in federal grants while enrolling less than 1% of all enrollees. 17 of these navigators enrolled fewer than 100 people each at an average cost of $5,000 per enrollee. The top 10 most costly navigators spent over $2.5 million to enroll 314 people. One grantee received $200,000 and enrolled one person. And over 3/4 of navigators failed to achieve their enrollment goals while spending more than $50 million. Ms. Turner, under the Trump administration, CMS has changed how navigators receive funding based on performance measures. Do you think that these changes help ensure accountability within the navigator program?
CMS has said in its report that it really is trying to respect that taxpayer dollars be spent wisely, and basically they are making the following year's grant contingent on a navigator meeting their previous year enrollment goals. And as you say, even with this generous funding, the navigators enrolled fewer than 1% of all enrollees in healthcare.gov. And so I think that we need to look at how can we get the best benefit, and they looked at private brokers and agents who live and breathe in this space, and they were much more successful, enrolling 42% of enrollees.
The subject of this hearing is about reversing ACA sabotage. Do you consider these efforts by CMS as sabotaging the ACA?
No, and the navigators were particularly, when the ACA was new, people didn't even know what a deductible was. So people needed to be educated about the fundamental principles of insurance. But now that we see in California, for example, there's been a 24% drop in new enrollees, despite their spending $100 million on marketing and navigators last fall. But they are finding many more people are having their coverage renewed and sometimes automatically renewed. So we're in a different space now with the ACA.
According to the Missouri Department of Insurance, since 2011, the annual cost of coverage per individual has increased by an estimated 235% in the individual market, and now there is only one option on the marketplace for my entire district, 7th District of Missouri. Do you see the efforts of the Trump administration to give states more flexibility to lower premiums and provide more insurance options for individuals as positive steps that can benefit consumers?
Absolutely, and I think that's what they're trying to do, both with the bridge plans, as well as association health plans, and as well as the Section 1332 flexibility, being able to tailor the needs, the insurance funding to the needs of their citizens is something that states can do much more effectively than the federal government.
So I'm assuming you don't consider these efforts as sabotaging the ACA?
I think they're really trying to give consumers new options, particularly those who are shut out of the market because of cost. And even many of the people with ACA coverage say, I might as well not have coverage because I can't afford the $6,000 to $10,000 deductible.
Thank you. And before I yield back, as a point of personal privilege, I was born in 1955. John Dingell was sworn into Congress in 1955. I had the great honor to serve with him for 2 terms. He, of course, the room downstairs is named after him. Yesterday morning, after an hour delay because of weather, we loaded up 2 plane loads of congressmen headed to his funeral in Dearborn and got up there and circled for an hour waiting for the temperature to raise 1 degree. If it would have raised 1 degree, we'd have made it, and we didn't. We were low on fuel. And so a legend in his own time, John Lewis, Representative John Lewis, and Speaker Pelosi, who were on the flight, along with Chairman Upton, Chairman Walden was there, Anna Eshoo. I'm not going to name all the names because I'll leave people out, but we held an impromptu service for John at 30,000 feet. And I just want to send out my best to Debbie. I know that John followed his father in Congress, and Debbie has followed him, and she's doing an outstanding job on this committee. And I just wanted to send my best and thoughts and prayers out to Debbie and the entire Dingell family, because we are sure going to miss him. I yield back.
Thank you, Mr. Long, for your comments about the Dean of the House, John Dingell. Mr. Ruiz is recognized for 5 minutes.
Thank you, Ms. Chairwoman. I and everybody in this room agrees that we need to do something about costs. The premiums are skyrocketing in the exchange. That's not the issue that we're debating here. When we look back at why the costs have gone up so much, all we have to do is listen to the insurance companies themselves, which have said and have warned that if we don't pay the cost-sharing reduction subsidies, they're going to increase costs. The other thing is they talked about the changes that were made by Senate Republicans to the risk corridors. They increased costs because of those. The other is because of the expired reinsurance programs, et cetera. And all these have been a part of the repeal efforts of the ACA. So when we look at the junk plans, this is not a solution to the problem of high cost. In fact, these junk plans will make cost higher in the exchange because this will siphon low, healthy, high corporate profit type patients into this lower risk pool junk plans, leaving behind the higher risk, more expensive type of patients for everybody else. So healthcare costs for everybody else will go up. And if there's something that I have learned as an emergency physician is that not every healthy person stays healthy forever. So I have seen a 48-year-old man in a motor vehicle collision who was previously completely healthy, who will now have traumatic brain injury symptomatologies for the rest of their lives and be paralyzed and require very expensive care and lots of medications. I have seen a 52-year-old man who comes in with yellow eyes and yellow skin who have been newly diagnosed with severe liver problems due to hepatitis, which is going to require expensive medications. And I've seen young and healthy 30-year-old women who come in with anxiety or depression, with new diagnoses of clinical depression, and also with a mass in their breast with a working diagnosis of breast cancer that has metastasized, which would require expensive chemotherapy. So even if those younger and healthy individuals buy this junk plan, healthcare costs will be more expensive for them because under these junk plans, they can choose not to cover their medication. They can choose not to cover their mental health coverage. They can start implementing a cap in lifetime coverage for these individuals that will need more care for longer period of times. We are not invincible. The whole purpose of health insurance is, what if you get sick? What if you get injured during an accident? And I have seen them, and I have counseled family members and patients about their terrible diagnoses or their terrible prognoses, and it's not a fun thing to do. So I have some questions in regards to costs. Ms. Keith, will junk plans increase costs for everybody else? And can you explain it further, please?
Yes, that's correct. Every analysis, including the Trump administration's own analysis, has found that expansion of these short-term plans through this new rule are increasing premiums in the ACA marketplaces. A study by the Kaiser Family Foundation that looked at what insurance companies actually said about their premiums for 2019 showed that the short-term plans, the individual mandate repeal, and the association health plan rule have increased premiums on average by 6%.
And so, you know, in one way, I'm hearing this opposing kind of arguments. Yes, we're for pre-existing, but we need to reduce cost. But it seems like by this junk plan, they're going to eliminate protections for pre-existing illnesses in order to keep costs down, because corporate insurance companies would love not to cover the sick. They'd like to cover the wealthy and healthy. So can you have it both ways in this junk plan? I mean, do they discriminate with people with pre-existing illnesses?
They absolutely do. I believe that's their business model, yes.
So if you support junk plans, you're supporting the idea that to take us back to a time where health insurances were allowed to deny or charge higher premiums or charge for higher or not cover certain procedures for those conditions. Is that correct?
Yes, it is.
Can you describe the medical underwriting process that Americans are subject to under these plans?
Sure. So it varies by insurance company, but essentially if you are applying to enroll in a short-term plan, you would fill out a very detailed health questionnaire about your own health, about the health of your family members, and maybe a medical history. You would also grant that insurance company access to all of your medical records. They would look at what prescription drugs you have taken. They would look at what medical exams you have taken. They would take that information and they would give you a price, or they would decline to cover you at all, or they would use that to dictate what benefits they will and will not cover.
Thank you.
Thank you. Dr. Bashan, you're recognized for 5 minutes.
Thank you, and just in light of my friend Dr. Ruiz's comments, it's about choice. If you have a pre-existing condition, don't choose a short-term health plan that's cheap. They don't discriminate at all, because it's a consumer choice. So to say that a plan specifically discriminates against people, that's just factually not true. They don't discriminate because it's about consumer choice. We're here today discussing legislative proposals that really do nothing, in my opinion, to address the high cost of health care and the lack of affordable insurance options for patients. One thing, again, Congress is here discussing the cost of health insurance plans, but again, we're not really addressing the true problem, in my view, which is the cost of the product is too expensive. And so if we all continue to chase a product that's too expensive and try to cover it, we're never going to catch up, in my view. The other thing is insurance is about risk. That's what insurance is about. So your description, Ms. Keith, is of all of these things about being assessed for what your risk is. That's what insurance is about. And so we need to figure out a way to cover people who have a lot of risk. And that's what Republicans did in our health care bill. We did it with high-risk pools. What is it? 4% of the people or 5% of the people in the country are 40 to 50% of the health care costs. So we want to cover people with pre-existing conditions, but we just want to do it in a different way. If you put everybody in the same pool, there's no way, based on the history of insurance and how it works, that actuaries will tell you that you can get the cost down for everybody and keep the costs low. It just doesn't work. So we want to cover people with pre-existing conditions. I was a physician before. I had people that I took care of that didn't have coverage. That's wrong. We just want to do it in a different way. So, Ms. Turner, do you think that any of the legislative proposals today would address the high cost of health care plans?
I actually think they would remove options for many consumers. 3 million people had dropped out of the individual market before the first short-term limited duration plan under the Trump administration rules was available. People are dropping out of coverage because they couldn't afford it. They want some options, and bridge coverage through the short-term plans provides many people an option. They should definitely be informed about these policies. But if they buy a policy and they say they buy a year policy and they're diagnosed with cancer, when they have that coverage, they're covered. And if they didn't have that option, they would be completely exposed to those costs.
Yeah, I think everyone here agrees on both sides of the aisle. We need more probably disclosure to consumers and make sure consumers, like someone mentioned, have it in big print right on the front page what your choice is here. You know, what the cost is, number one, but number two, what actually is included in these plans, right? And you're right, if you are underwritten and you're high risk, you're probably not going to be able to get insurance through one of these plans. That's not the point. That's not who we're trying to cover. But in the Affordable Care Act, I hear from constituents all the time that the plans are just not affordable in the Affordable Care Act. And so we need to work together to try to find a way to improve that. And, one of the things I think that we can do is work on the cost of the product. And I keep saying that because Congress always works on trying to provide coverage but not trying to get the cost of health care down. So, Ms. Turner, how do you think repealing the Trump administration's guidance on Section 1332 innovation waivers would impact the affordability for patients in states with waivers?
The states that have received waivers so far have been able to reduce premiums anywhere from 43% to 7% in the states so far that we have numbers for. And so those citizens would definitely be adversely impacted by being thrown back into the same pools that don't provide states with the same flexibility and the same options that they would have under this new guidance to be able to provide more affordable options for their residents. And about the essential benefits in the ACA may not be everything that somebody needs. Janet, that I talked about in my example, needed to have her anti-rejection medicines covered, and they were not covered under her ACA compliant plan. So states need to be able to make sure the plans work for their citizens.
I want to briefly talk about cost-sharing reduction payments, which everyone is saying is sabotage the ACA. That was a bailout, in my opinion, put into the law so that if the pools didn't work, insurance companies were losing money, they had a federal backstop with the taxpayers footing the bill. I yield back.
Thank you. Ms. Custer is recognized for 5 minutes.
Thank you, and thank you for your testimony. I appreciate it. I want to join my colleagues in honoring John Dingell and our Mile High Memorial yesterday for him, and we'll all be together with Debbie Dingell, our colleague, and her family tomorrow. I just want to move on to the Section 1332 and direct my questions, if I could, to Professor Keith. There's clear statutory directive in Section 1332 that states must provide comprehensible and affordable coverage to a comparable number of residents under the ACA. But unfortunately, last fall, the Trump administration issued new guidance, and I'm afraid that that's going to hurt people with pre-existing conditions like my dear friend Bodie, who's a young man with spinal muscular atrophy in my district, necessitating a wheelchair to get around. Thanks to the ACA, there's no longer broad-based exclusions to wheelchairs or to all the other affordable health care that helps Bodie lead a fulfilling life. But for Americans like Bodie, this concerns me in this Trump guidance because it runs counter to the statutory directives. So last week I introduced H.R. 986, the Protecting Americans with Pre-Existing Conditions Act, to nullify the new guidance. I've heard from my Republican colleagues this morning that they want to protect Americans with pre-existing conditions, and I would encourage them to sign on to my bill. If I could, Professor Keith, I'd like to suggest a quick lightning round about my concerns of these short-term, limited duration insurance products so that Americans will understand our concerns. If you could just respond, under these plans, Are insurers allowed to refuse to offer a policy to an individual with a pre-existing condition?
Yes, they are.
And are insurers allowed to exclude coverage for pre-existing conditions?
Yes.
And are insurers allowed to charge higher monthly premiums based on health status and factors such as age and gender?
That is correct.
And are insurers allowed to impose annual or lifetime dollar limits on care?
Yes.
And are insurers allowed to opt not to uncover entire categories of benefits? Here I'm thinking of mental health services, prescription drugs, or maternity care.
That is correct.
And are insurers, even in states like Pennsylvania, New Hampshire, West Virginia, that have been so hard hit by this opioid epidemic, allowed to offer policies that do not include coverage for substance abuse treatment?
That is correct.
And are insurance allowed to retroactively cancel coverage once care is needed?
Yes, that has been one of the biggest abuses and something that the Affordable Care Act prohibited.
And are insurers allowed to impose much higher out-of-pocket costs than under the Affordable Care Act?
That's correct.
And so I would simply ask you or Commissioner Altman, if you could, we've heard from Ms. Turner about her opinion that these plans protect consumers and bring down costs. Are there alternatives, waivers such as reinsurance products that could bring down costs for consumers?
Absolutely. There are other mechanisms out there, and reinsurance is a great example that can lower costs for those to help afford premiums without putting people in the position of having to choose between no coverage or substandard coverage like these short-term plans provide.
So it's your professional opinion that rather than this list that we've gone through this morning of ways that insurance companies are choosing to make higher profits, and I believe you've testified the profits are as high as 50% of every premium dollar?
Actually, there are some even higher than that. The two largest carriers with 80% of the market do spend less than 50 cents of every premium dollar on care. The rest is some administrative cost and the rest profit.
Which is shocking to the American people. Rather than all that premium dollar going into profit while families are put at risk, you believe there's an alternative that this committee could consider to focus on reinsurance or risk pools?
I do, so that no one has to choose between their health and their financial well-being.
Thank you. My time is up, but I very much appreciate that.
You're welcome.
I yield back.
Thank you. Mr. Gianforte is recognized for 5 minutes.
Thank you, Madam Chair. And I thank the panelists for being here and your testimony. Hardworking Montanans regularly tell me how their health care costs continue to rise and benefits shrink. I was just had a town hall this week, and individuals in Missoula and Livingston, Montana, both raised this very issue. It's a real burden on families in Montana. Obamacare has not provided an affordable option for many Montanans. In the first year of Obamacare, more than 20,000 Montanans lost their coverage because of the law. And in the first 3 years under Obamacare, Montanans' premiums have shot up 66%. And we had testimony, we've had similar experience in Pennsylvania. Unfortunately, premiums continue to skyrocket for Montanans and Americans across the country under the current scheme. Thankfully, the Trump administration is empowering states to address these rising healthcare costs by allowing states greater flexibility with the strict federal mandates of Obamacare. The Department of Health and Human Services is effectively allowing more Americans to get coverage that best suits their needs. The administration has implemented rule changes that expand state innovation waivers to improve access to short-term, limited-duration insurance plans, eliminate the costly individual mandate penalty, expand association health care plans. These measures entrust consumers to pick the best health care for their family. Let's be frank, Obamacare has robbed consumers of choice. Obamacare asserted that a Washington bureaucrat knows an individual's health care needs better than she does. The Trump administration changes are empowering consumers so they can make health care decisions that work best for themselves and their families. Providing waivers empowers states to promote innovation that benefits patients and consumers. The state innovation waivers, originally born in the Obama administration and expanded under President Trump, allow states to be creative with health care solutions while saving money and lowering premiums, which is the issue I hear over and over again as I travel our state. Alaska has taken advantage of the waivers. We've talked about this. They saw premiums drop in some plans by over 40%. We heard testimony today. Similar experience in Maryland and other states. Unfortunately, for a second week in a row, members of the majority here have put on a political theater. They want the American people to believe that there are lawmakers who oppose protections for Americans with pre-existing conditions. I don't know of any Democrats or Republicans on this committee that are in favor of this, who want to strip protections for Americans with pre-existing conditions. We all agree on that. There's broad bipartisan support here. I think we should work together to find permanent legislative solutions that protects people with pre-existing conditions. I also think we should work together to continue empowering states to innovate and address healthcare affordability. I know that's the issue back in Montana. And we should encourage innovation and affordability, not terminate efforts to improve healthcare and make it more affordable. Ms. Turner, these state innovation waivers that allow for flexibility and creativity for the states who want to find cost-saving solutions, do you think that we would continue to see this sort of cost savings and innovation if we move to a single-payer, government-run Medicare for All program?
No, and I think what we'd find is that the American people would see, they would not have any choice. It would be the single-payer government program, whatever form that takes. And what we're seeing is the states are so much better able to be able to fine-tune funding to the needs of their citizens. The American Health Care Act that this Congress passed in 2017 provided specific money to the states, $123 billion, to be able to help with those high-cost patients. So they had better protection than being thrown into the same pool and often having benefits denied.
Yeah, so what would the effect be of stopping these the state relief and empowerment waivers on individuals in the states where that ability to innovate was taken away?
The states would basically become functionaries for the federal government. It would really undermine our system of government, I think, and giving the federal government so much control. One of the things that we've learned through these waivers and through the 70 changes plus that have been made to the ACA so far is that we need to have more flexibility and more state control.
Okay, thank you, and I yield back.
Thank you. Mr. Starbanes, you're recognized for 5 minutes.
Thank you, Madam Chair. Thank the panel for your testimony. Ms. Ullman or Ms. Keith, maybe you could tell me the short-term plans that we've been talking about, the people offering those plans can and do deny people or reject people based on a pre-existing condition. Do they not in some instances?
They do, that's correct.
Yeah. So it's incompatible, it seems to me, to claim, as we're hearing from a lot of the members on the other side, that they absolutely want to protect people against discrimination based on pre-existing conditions on the one hand, but to defend these short-term limited duration plans on the other hand, because those plans actually put people in that position of being able to be denied based on that situation. Would you agree there's some incompatibility there?
I think that's correct, and these short-term plans exacerbate, I think, many of the out-of-pocket costs that everyone in this hearing has said they're concerned about. So folks who maybe are healthy enough to enroll in a short-term plan but then become sick can face catastrophic costs that should concern all of us.
It's this distinction that we were able to focus on when we put the ACA together originally, where people are seduced into thinking that they've got their health situation covered and are doing that relatively inexpensively, only to then find, if they do get sick, that they're out of luck because the deductibles are incredibly high, or the benefits that they thought they would be entitled to are not available to them. There were the caps that the insurance industry would place on how much it would cover. So, in a sense, you're buying the health care equivalent of a pig in a poke when you're buying these short-term limited duration plans. Why, by expanding the duration of them up to a year, we wouldn't view that as going back to the bad old days, which were the thing, which produced all these stories of heartache that motivated us to try to make these changes. I can't understand for a moment why anyone would support that kind of a policy shift. But I wanted to ask you a specific question, which is that these short-term junk plans, as we're calling them over here on this side, where they can reject a beneficiary based on HIV status, based on weight, pregnancy, other kinds of things. Could somebody apply for one of those plans, check a box saying they don't have a pre-existing condition because they're not aware? I mean, that was the other thing we discovered when we were doing this. How many things qualify as pre-existing conditions that no one would ever imagine would disqualify them from coverage? So somebody could get into a plan, and then when they go to get the benefits of it, they would discover then that they're not qualified for those based on this pre-existing condition disqualification. Could that happen? And so then you're trying to access it, and boom, you can't access it, and not only that, you're thrown off the plan at that point because they say, oh, you weren't qualified in the first place, after you've paid premiums for I don't know how many months, and I don't know whether you'd get those back. But is that a fair dilemma that people can find themselves in?
That is absolutely correct. What you're describing is something called post-claims underwriting that an insurance company would use to go back and see if there's something that the consumer did not disclose or something in their view they omitted. What the insurance company would typically do is retroactively cancel the policy altogether.
Yeah. So basically, these did you want to comment?
I'm just going to add, I think it's important to note that we're not talking about cases where patients intentionally did not disclose, because
Right.
true fraud has always been a reason. Cases where something was noted on a medical record that they may not have remembered, potentially didn't even know about because their doctor wrote it in the notes without explaining to them, or in the case that I listed in my testimony, they were never diagnosed or sought care but were experienced symptoms for which the insurer deems they should have sought care.
I mean, this is, I have to yield back my time, but just to say, we're inviting people back into a world with mirrors and trapdoors. That was exactly the place we wanted to get away from when we passed the ACA. So we got to really push back against these junk plans. And with that, I yield back my time.
Thank you, Mr. Sarbanes. I now would like to recognize the gentleman from Georgia, Mr. Carter.
Thank you, Madam Chair, and thank all of you for being here. Certainly an important area, that is affordable health care costs. You know, before I became a member of Congress, I practiced pharmacy for over 30 years. I started when I was 2, but nevertheless, one of the things that I heard so often was the cost of health care, and particularly the cost of insurance. And that's something that I was committed to work on, and I am committed to work on, continue to work on as a member of Congress. Ms. Turner, I read an article in Axios the other day that said that 42% of people participating in an individual marketplace weren't able to use their insurance because out-of-pocket costs were so high or their deductible was so high. And it's my understanding that that's why we have the 1332 waivers, is so that states can actually address this issue. I believe in your testimony you gave examples of some states where it has actually worked, maybe Alaska, Oregon. Can you repeat that for me, please?
Yes, Congressman, the 1332 waivers really are designed to give states flexibility to separately subsidize the people with predictably high health care costs that are driving up the premiums for everyone else. They're the ones who are causing premiums to go up as the healthy people drop out. And a number of states have applied for waivers to, in different ways, subsidize them. Alaska said, we'll look at these 33 categories, and if people qualify for those, then they will be able to get separate subsidies. Others have reinsurance, high-risk pools, invisible high-risk pools. States are working to figure out how to do this with dramatic results. We see, for example, in Alaska, that premiums went down by almost 20%, enrollment went up by 7%. In Minnesota, premiums went down again by almost 20%, enrollment went up by 13, 14%, and on and on.
And that's the point I'm trying to make. I mean, obviously, this has helped. It's helped tremendously, and expanding it has helped. Yet the impetus for the hearing today is a set of bills that are actually going to constrict this. It said that we're not going to have the ability to expand on this and enjoy the benefits of it working like it has worked. I'm really confused by that because this is our second hearing in the committee that has the broadest jurisdiction over healthcare costs of any other committee in Congress. And I'm just trying to figure out where we're going. The first week, we had a hearing on a lawsuit that is still in litigation, has not been settled yet, and may not impact anyone. Here we're having a hearing this week on what's going on and how we can actually constrict the affordability and make healthcare costs even more expensive for people. And yet, when I'm in my district, people are talking about, what about prescription drug pricing? Well, we haven't even discussed prescription drug pricing yet. Yet there are other committees in this House, the Ways and Means Committee. Yesterday had a hearing on prescription drug pricing. The Oversight and Government Reform Committee's already had a hearing on drug pricing. Yet here we are in the most broadest jurisdiction of healthcare, and we haven't had a prescription drug pricing hearing yet. Madam Chair, I certainly hope that we'll get to that at some point here because it is extremely important. The point here is that people being able to buy health insurance doesn't help anyone if they can't use it. You know, when I first went into business, I read something and it said, when is a deal not a deal? It's not a deal when you buy something you don't need or you can't use. And that's what people are being forced to do, buy insurance that they can't afford to use. That's not helping them, and that's what we need to be addressing here and what I hope that we can address. Let me ask you, Ms. Turner, when folks have a gap in coverage and employment, or people who retire and are not yet eligible for Medicare, what are the options for them?
Previously, under the Obama administration, they had the option to buy a short-term plan. These have been around for decades, but it could only last for 3 months. And people generally, if they are in gaps in coverage, they need coverage for longer than that. So this is what the Trump administration did. It said that you can have the policy for up to a year, and it can be renewable for another 2 years.
And in these plans, they're options. So they give these people who are in this gap, if you will, the ability to actually fill in that gap and the ability to have coverage, which we all want. Ms. Turner, I really appreciate all of you being here and appreciate this opportunity. And Madam Chair, again, I look forward to the hearings that we're going to have on prescription drug pricing, and I yield back.
I thank the gentleman. I look forward to them as well. I now would like to recognize the gentlewoman from Illinois, Ms. Kelly.
Thank you, Madam Chair, and thank you to all the witnesses. And I, too, want to salute Congressman. Yes, I do. Thank you to the witnesses. Thank you, Madam Chair. And I, too, want to salute Congressman John Dingell for all of his work, and he will be sorely missed. The Trump administration has recklessly expanded junk health plans that do not offer comprehensive coverage. These junk plans could unwittingly leave, as we've heard, families on the hook for thousands of dollars of health care costs. According to an article in the New York Times, Kevin Conroy, a patient from California, had a heart attack and underwent triple bypass surgery 2 months after enrolling in a short-term junk plan. His insurance company refused to pay for any of his treatment, leaving him with a $900,000 bill. In another case, United Health refused to cover a patient's breast cancer treatment, leaving her with a $400,000 bill. The insurance company claimed that breast cancer was a pre-existing condition, even though the patient was not diagnosed with cancer until after she bought the junk plan. Ms. Altman, according to your testimony, I understand that in your state, several consumers have been stuck with large unpaid medical bills because a short-term policy denied coverage even for medical conditions arising after an individual enrolled in a policy. These conditions should theoretically be covered since they arose after individuals enrolled in the plan, but often the insurance company, as we've discussed, that sell these junk plans refuse to pay out. You've explained about post-claims underwriting, and also we talked about how consumers need to be more educated. But I want to know, where does all the money go if these insurance companies are not using premium dollars to pay for health care?
Sure. So, as we've talked a little bit about, Affordable Care Act plans are subject to a medical loss ratio that ensures that they spend at least 80 cents of every premium dollar on care, with the remainder going to administrative costs and profit. And if they don't meet that standard, they are required to refund dollars to their policyholders. The short-term market, on the other hand, averages, based on a study, 64 cents on every dollar. The largest carriers average less than 50 cents a dollar spent on care, with one of those carriers spending only 34 cents on the dollar. So the remaining funds would go some to administrative costs and the remainder to profit. I think all evidence points to these being very profitable lines of business for the insurers that sell them.
Thank you. And also, I agree with my colleagues. I want us to work together too and get something done for the American people. But as I recall, in the last years, all I've been given the opportunity to do is vote to repeal the Affordable Care Act or tear up some part of it. And Ms. Turner, I know you've been more negative about the navigators, but also beside the marketing, the time period was cut so short, so it was harder for people to register. And we talk about the economy's better, so I'd like to think we went down some because people got jobs, and so they did have health insurance. So I just want to know from you, do you think the ACA has been helpful to anybody?
Oh, absolutely. And actually, California extended its enrollment period to, I think, the middle of January, and they still were down 24% in new enrollment. So I think that the real issue is, how do we make these plans more attractive to people so that they can afford both the premiums, especially if they're not in the subsidized market, as well as the deductibles are low enough that they feel they can actually access the insurance. And that's what I'm hopeful that states will take advantage of the 1332 flexibility in the law to allow that.
Okay, thank you for your answer. I just want us to also recognize that there were many, many millions of people that had no insurance. And just like people can talk about the stories they're hearing, there are many stories that even in my own family, how people that weren't insured have insurance, and they are very happy.
And they're grateful, yes.
I yield back.
Thank the gentlewoman from Illinois, and I now am pleased to recognize the gentleman from North Carolina, Mr. Hudson.
Thank you, Chairman Eshoo, and this is my first chance to publicly congratulate you on taking the gavel. I look forward to finding common ground and working with you throughout this Congress. When I noticed today's hearing title, Strengthening Our Healthcare System, Legislation to Reverse ACA Sabotage and Ensure Pre-Existing Conditions Protections, one word really stood out to me, the word sabotage. I know my colleagues and I on this panel agree that we should strengthen our healthcare system. I talk to constituents of mine every time I'm home who need better access to more affordable care. And I know my colleagues and I want to ensure protections for pre-existing conditions. That was universally accepted at our hearing last week. But the word sabotage really stuck out at me. Unfortunately, this conversation around healthcare has become increasingly partisan. We saw this with the Affordable Care Act, and we saw it again with the American Health Care Act last Congress. But this conversation should be bipartisan. Because healthcare is an issue that affects every single American. From the time we're born until the time we die, there'll never be a time when the healthcare industry doesn't touch our lives. I was talking to a constituent last week who he and his wife are in their 50s. He told me his wife couldn't afford to buy health insurance on the exchanges, but because of the short-term insurance plans now being offered, she was finally able to purchase insurance that they could afford. He noted that on her previous insurance, if they paid all their premiums and met their deductible, they would have spent $18,000 out of pocket before they accessed the first bit of health care. So that brings me to today and this word sabotage. I don't think these short-term plans are a long-term solution for people buying health insurance, and the administration agrees with that, which is why they're only available for up to 3 years. But they do help provide options for folks back home who feel like they have no place else to go. I definitely don't see them as sabotaging the ACA, more so as enhancing the intent, however misguided the execution of the ACA of providing more people with health insurance. Ms. Turner, in your testimony, you noted these plans are helpful for early retirees like my constituent who need to bridge the gap after losing employer-sponsored health care. I think that's definitely true with the folks I've talked to. But one criticism of the short-term plans I've heard today has been that consumers may not be sufficiently educated on the restrictions and limitations that come with these policies and may not understand the trade-offs for lower premiums. In my conversation with my constituent, he recognized his wife did not have coverage for everything, but that the plan covered everything they needed. Ms. Turner, yes or no, the final rule provides a disclosure notice that must be prominently featured on the insurance materials. Is that correct?
Yes, sir.
It appears from my anecdotal experience that those disclosure notices are working. Would you agree with that?
Yes, sir.
I appreciate that. One other issue that has been raised, that and if I could stick with the John Dingell yes or no answers. Ms. Keith, I believe New Jersey and California have limited or banned the sale of short-term limited duration insurance plans. Is that correct?
That is correct, yes.
And Commissioner Altman, do other states have the authority under the Trump administration's action to limit or ban short-term limited duration plans if they choose?
Yes.
Well, so if that's true, then that if any state doesn't like the new arrangements, they're free to pass their own laws limiting or banning short-term limited duration insurance plans. I think that's just important to note for the record that states have the option here, and states are looking for solutions for their constituents. A lot of them in the cases like the one I described to my constituent who are just trying to bridge a gap, who are trying to find a way to afford insurance for their families. So I think it's important to note that we're not forcing anyone into this. We're giving flexibility to the states. And I would love to see us do an extended hearing, Madam Chair, where we bring in some folks from the states to talk about are these plans really working. We hear a lot of discussion from the other side about this could do that, it could be that. But let's look at what the facts are, what's really happening in the states. I think that would be really important. So with that, I'll yield back.
I thank the gentleman. I now would like to recognize the gentlewoman from Delaware, Ms. Blunt Rochester, a new member of the committee. We're thrilled that you're here. You're recognized for 5 big minutes.
Thank you, Madam Chairwoman. And also thank you to the witnesses today. I also would like to send my condolences to the Dingell family on the passing of such a legend as John Dingell. In 2017, in January, the Trump administration halted all ACA marketplace outreach for the final week of the 2017 open enrollment, and then slashed ACA enrollment funding for advertising and outreach by a staggering 90%. 90%. Delaware's marketplace, forced to do more with hundreds of thousands of dollars less in funding, saw a decrease in enrollment every year since then, down 20% since the state's peak enrollment in 2016. The administration's repeal efforts and damage to the Affordable Care Act have resulted in new enrollments going down and costs going up for the over 22,000 Delawareans and 8.5 million Americans receiving their health insurance through the individual marketplace. These Delawareans are now paying more than $100 in premium costs over what they paid before, over the national average. And I heard my colleague, Mr. Hudson's point about the word sabotage. And as I was sitting here thinking of what I would even say, the saying, if it walks like a duck and quacks like a duck, it must be a duck, came into my head. And it came into my head because when you shorten the amount of time that people have to apply, and then you couple that with slashing information and outreach to people, it appears it feels like sabotage. And I am really proud to have been able to introduce the More Health Education Act to restore funding for educational outreach. All of the bills that we're discussing here today will help Americans enroll in quality comprehensive plans in the marketplace, and they will ultimately lower costs. But more importantly, the goal is to make Americans healthier. And so my first question is, number one, I just want to clarify, Ms. Turner, that this particular bill was for marketing and outreach and not the navigators, but you will probably see more coming forward. But I wanted to ask Ms. Keith to clarify something that was stated, that marketing doesn't work. Can you just talk about, does marketing work? People say we already know about the ACA. Why do we need to have marketing? Can you share a little bit about that?
Thank you for that question. It's very important. Multiple studies, including studies conducted by CMS itself, have shown the value of advertising and marketing outreach under the ACA in particular. One of the changes by making such dramatic cuts to the advertising budget is that beginning in 2018, CMS ran no TV advertisements, even though that was one of the most cost-efficient ways of reaching people and had a measurable impact on people enrolling. I think Ms. Turner has cited California having lower new enrollees this year. I think it's worth noting that California has had the same enrollment overall, and I think part of that is that new enrollees, California had strong enrollment of new enrollees in previous years, and I think the state would point to things like loss of the individual mandate as reasons why perhaps new enrollment is lower, but I did want to clarify that enrollment in California is stable.
Gotcha, great. And also I wanted to follow up with that. Why do you think we still need outreach and marketing?
Awareness remains low. Documented studies have shown this. Even as of November of last year, there were about 69% of uninsured consumers and consumers who would purchase individual coverage who did not know the deadline was December 15th or had the date wrong. 69% of folks who we are trying to reach for this type of coverage who would be eligible are not aware of their options, and outreach and marketing plays a key role in that. I would just emphasize that we are seeing very aggressive marketing of these short-term plans as well, and so as we've seen cuts to ACA outreach and marketing, it's being filled. This void is being filled by these short-term plans, and it's very confusing for many consumers.
And Commissioner Altman, can you talk about the state of Pennsylvania and what impact these kinds of cuts have had?
Sure. So Pennsylvania, under a prior administration, chose to use the federal exchange. So we rely on CMS and the federal government to operate our exchange, and marketing and outreach are supposed to be a core element of that. And so in my perspective, when the federal government ceased doing that and ceased trying to reach out to Pennsylvanians, they weren't meeting those obligations, but they still needed to be met because people are not aware. The number of consumers I talk to who don't know basic information, we've tried to fill that gap with our own campaign, but our resources are certainly limited.
Great. Thank you so much for your questions. I would yield back my time in a minute, but just to say that even as a member of Congress, we were limited in what we could say. So I applaud the work of the committee, and I yield back the balance of my time.
Thank the gentlewoman, and we're thrilled that you're part of the committee. It's a real pleasure to recognize the gentlewoman from Indiana, a wonderful colleague and a good friend, value added no matter where she is in the Congress, Ms. Brooks.
Thank you, Madam Chairwoman, and I just want to also have the opportunity, this is my first opportunity to publicly congratulate you on leading this important committee, and I look forward to continuing our work that we've done in the past, particularly on Pandemic All Hazard Preparedness Act and many other areas, and look forward to your work and working with you on this most important subcommittee. I want to focus a little bit on the marketing because my colleague talked about marketing, and Ms. Turner, marketing and outreach is an incredibly important aspect of any product. I assume you would agree with that. However, the more products and the more choices there are, marketing, there have to have products that people want to consume and or want to and or understand what it is they are consuming. And like so many others, I have many Hoosiers who have shared with me that the high cost of the premiums and the high deductibles are what so many, their barriers have been to purchasing a lot of the products. So can you help us understand why having more choices, however, it needs to be informed choices. And I agree that there is a concern, whether it is with different types of products, people have to understand what they're buying. And that's, I think, what the biggest problem is with these short-term products, is they don't quite understand what is covered and what is not covered. Can you please talk with us about why having more choices is better for healthcare overall for consumers, regardless of their health status?
Well, it does give them options. It gives them options of networks, doctors, the hospitals that are available to them. And unfortunately, in I think about half of counties, people in ACA coverage have a choice of one plan. It's take it or leave it. So there's really no choice there at all. And people who can't afford that coverage are now being given other options through short-term plans and other administrative ideas.
Can you share with us a little bit about how the federal government might be able to increase enrollment? Are there other ideas that any of you might have as to how the federal government might be able to increase enrollment in health insurance, aside from spending money on marketing and navigators?
If the policies were more affordable, if there were more competition in the market so that one provider doesn't have the opportunity to buy up all the doctors and hospitals and charge higher premiums, giving people more competition in these markets, so looking at the anti-competitive monopolies that some of these hospitals and systems have is important, but also providing more options through Section 1332 for states to tailor their risk models so that the highest risk people are not in the same pool with everybody else and driving up premiums, driving the healthy people out. I think this has got to be a state-based solution, and the 1332 that was a part of the original ACA was envisioned to give states that flexibility.
Talking a bit more about that, how have Section 1332 waivers, have they increased access to care in the states that have approved waivers? And can you give any examples
Absolutely.
of access to care?
Access to care, and which is, of course, in many people's case, it's access to coverage to help finance that care. But in Arkansas, Minnesota, Oregon, Maryland, Maine, New Jersey, Wisconsin, those are many of the states that already have requested waivers to spend some part of the ACA money themselves in a way that does a better job of risk mitigation, high-risk pools, reinsurance, invisible high-risk pools, to separately subsidize the people who have the highest costs so that you can then lower premiums for others in the individual market and attract more people, which then further lowers premiums. Everybody wants more healthy people in these insurance pools. The ACA is working against that. Section 1332 gives states tools to be able to get more healthy people into their markets.
Thank you. I yield back. Val, it's my time.
Thank the gentlewoman, and it's a pleasure to recognize from California another new member of our subcommittee, and she's so welcome, the gentlewoman, Ms. Berrigan.
Thank you, Madam Chairwoman. I want to thank you all for joining us here today. We've heard a lot about these junk plans. In my first term as a new member of Congress, there feels like we just had all kinds of conversations about health care, and it was centered around repealing the Affordable Care Act, which would limit access to health care to people. So it's nice to be able to have this conversation and actually have a debate on what some of what has been happening over the last 2 years is doing to pricing, and as a result of some of the policies that have been implemented for the last 2 years. I myself am a co-sponsor of what we're talking about today to eliminate these junk plans, and I want to talk a little bit about that. One of my colleagues on the other side said, let's talk about the facts, let's talk about what is happening. We received the story of Sam Bloschel from Chicago, and I want to share his story because I think it's important to highlight what is happening and what people are going through. Now, Sam's story was brought to us by the Leukemia and Lymphoma Foundation. Sam unknowingly enrolled in a junk plan after he was deceptively steered into it by a broker. Now, Sam had been experiencing back pain, and he was completely transparent about this when he talked to the broker about his condition. Sam writes in a letter to the committee that he thought it would be smart to talk to a broker about upgrading his coverage so he could have better health care access for any future medical care. Now, the broker assured Sam that the junk plan was the right insurance plan for him, given his back pain. Now, after enrolling in the junk plan, Sam was diagnosed with an aggressive form of blood cancer, non-Hodgkin's lymphoma. After undergoing 6 months of chemotherapy and radiation, his insurance company informed him that they were not going to pay for the treatment, leaving him with $800,000 in medical bills. The insurance company also refused to pay for a bone marrow transplant, treatment necessary to allow Sam to achieve lasting remission. Now, Sam writes in his letter that the insurance company claimed that cancer was a pre-existing condition because he had previously visited a chiropractor for his back pain. Now, Sam was left with almost $1 million in medical bills and no health insurance for the treatment that he needed in order to stay alive. Now, while fighting cancer, Sam is also trying to figure out how to avoid bankruptcy. Now, Sam is only 32 years old and a business owner. He writes that instead of planning for his future with his fiancée and building his business, he's left up at night wondering how to stay afloat. So I want to start by entering Sam's letter to the committee into the record now. And I also, Madam Chairman, Chairwoman, could I answer that too? Thank you very much. Ms. Keith, can you discuss how insurance companies are able to essentially defraud patients like Sam?
Certainly. So it sounds like Sam was a victim of something called post-claims underwriting, which is something we've been discussing, where his back pain, which he disclosed, was used as a reason to deny coverage for his cancer treatment and care, leaving him on the hook for all these bills. I think other ways that short-term plans have exposed consumers to high out-of-pocket costs like this is through their refusal to cover pre-existing conditions, the benefit gaps. But even when you think you fully understand the product and you disclose your back pain and you think you know what you're getting, to be surprised that your cancer treatment wouldn't be covered, I think is something that is very troubling for patients and consumers, the stories that we're hearing all across the country.
Right. Commissioner Altman, could you describe the impact of the Trump administration's decision to expand the junk plans on patients who may be in a similar situation to Sam?
Yes, and thank you for sharing that story. I think that story is so indicative of many of the pieces we've talked about today, from limited benefits to deceptive marketing practices, which are, for the record, illegal, to post-claims underwriting, and frankly also to the fact that something like this can happen to anyone. And that is why every person needs comprehensive health insurance to cover things like unexpected cancer diagnoses. And this story is also one that demonstrates these short-term plans are not that.
Well, thank you. I know Sam writes that somebody shouldn't have to worry about filing for bankruptcy or getting stuck with $800,000 in medical bills. I agree. I think that's why we're having the hearing today. I also think that's why having legislation to protect individuals like Sam and reverse the administration's attacks on Americans with pre-existing conditions is important. And with that, I yield back.
I thank the gentlewoman. I'm now pleased to recognize the ranking member of the subcommittee, Dr. Burgess, for 5 minutes.
Thank you for the recognition. Thanks to our witnesses for being here. I know it's been a long morning and now afternoon, but I appreciate your input into this important subject. Ms. Turner, let me ask you, probably 2 years ago, I guess in March of 2017, the Health Affairs published the article on the invisible high-risk pools that the state of Maine had used to rescue its insurance industry after their attempt at community rating guaranteed issue got them into so much difficulty in the individual market. The invisible risk pool was a way to sort of reconstitute that market. Would you qualify those as junk plans?
I think that the risk pools actually provide the social safety net so that if somebody does wind up in a situation like Janet that I described in Colorado, who had insurance but when she was diagnosed with hepatitis C, the high-risk pool in the state was there to provide her care and ultimately pay for her $600,000 liver transplant. So there are other options available than the ACA, and we've seen those in the past, and Maine is another example.
Great, thank you. And Madam Chairwoman, just before we finish up, I am going to have a couple of unanimous consent requests so that I don't get gavelled out. I'd just like to make that information available to you. And Ms. Turner, staying with you, one of the issues I brought up in my opening statement was the issue of global budgeting. Can you speak to the how a global budget system would impact patients and the healthcare system at large?
Whoever controls the money is going to control the choices. And whoever is controlling that global budget, whether it's a regional health administrator, whether it's a federal bureaucracy, whether it's a hospital system, is going to control the choices for that patient. And they're going to allocate the money in a way that I'm sure they will believe is going to be the fairest way possible, but it always winds up, they wind up with shortages, they wind up with waiting lines. We've seen in in Canada, that hospitals have to close in December because they've run out of money. So I think that it significantly diminishes individual patient choice, and it often leads to rationing of care.
And just while we're on the subject of Canada, is my understanding that Canada, as opposed to the system in the United States, where if a bill is submitted by CMS, it's paid. In Canada, there's a fixed budget, and once that budget is exhausted, the bills are held until the next year. So a fundamental difference in the approach. One of the things that has concerned me for some time is that you do see that there is an effort to create a single-payer government-run system, and you see this not just in the United States. I mean, this has been something that's been ubiquitous across the world. Why is that? Why does a country want to control something that inherently should be an individual issue?
Now, I've thought about this for many years, and I do believe that there is a sense of fairness, that if everybody's in the same system, that everybody will be treated the same, but that is not the way that it works in any country that has some form of a government centralized healthcare system. The affluent people always find a way to buy out of it, and people who have fewer means always wind up with their care rationed and limited.
So does it concern you, some of the statements we've heard about pushing to that type of system, particularly those that say we're going to void any private insurance, where the large group market would disappear of necessity under a single-payer system in this country?
With 173 million people in the employer health insurance market that value their coverage, I think that would be very problematic. When you have 60 million people on Medicaid that value that coverage and that would see it compromised if we had another 70 million people on that program. So I think that the system as it has evolved over decades, and I think it's important to build on that system and figure out how do we help these 15 million people who are in the individual market, who are the most exposed to the high premiums and the high costs, the high deductibles, and the possibility of losing their coverage.
I do know when I ran my medical practice, obviously I was in the small group market. When I bought insurance for my employees, I would have welcomed the ability to go into an association health plan. If county medical societies across the country had put together a group health insurance model, that would have been welcome news for me, and those patients would have been protected from pre-existing conditions, unlike others in the individual market. So thank you so much for your time today, and I'll yield back.
Thank you, Dr. Burgess. Let's see. It's now my pleasure to recognize the gentleman from California, Mr. Cardenas.
Thank you very much, Madam Chair and Ranking Member, for putting this very important hearing together in full view of the public. And I want to thank the witnesses for being here as well, the ones I agree with and the ones I disagree with. Thank you so much for providing your perspective. Since the passage of the Affordable Care Act in 2010, more than 20 million Americans have gained meaningful access to insurance coverage. Before Donald Trump became president, the uninsured in this country fell from 18% to 11%, the biggest jump in any period of time in the country's history. Yet basically, since day one, the Trump administration has actively undermined the law and attacked Americans' health care. The administration cut the advertising and enrollment budget from $100 million to $10 million. This has had a very real consequence, and I have heard stories from my own district where constituents mistakenly believed that the health care exchanges ended with the presidency of President Obama. The administration's sabotage efforts have resulted in the highest uninsured rate in 4 years. According to a Kaiser Family Foundation study, over 80% of uninsured adults were not aware of the deadline to enroll in coverage in 2017. Again, it was this Trump administration that reduced the Enrollment Administration's advertising budget from $100 million to $10 million. Another survey by the Commonwealth Fund said that 41% of uninsured adults are still unaware of the ACA marketplaces or that subsidies are available to help them pay for coverage. The Trump administration is strangling health care for millions of people and undermining the law of the land. Ms. Keith, I understand that uninsured Americans are less likely to be aware of the deadlines or availability of affordable coverage. Is that a correct statement of today?
That is correct, yes.
Okay. Also, Ms. Keith, can you briefly describe how gutting funding for outreach and enrollment impacts new enrollments?
Certainly, new enrollees tend to be younger and healthier. As you can imagine, patients who are older and have health conditions are very motivated to enroll in coverage. It's really younger and healthier consumers who aren't aware and need to better understand the marketplace options available to them. What we've seen is since 2016, new enrollment through healthcare.gov is down by about 50%. We need younger and healthier consumers to help keep the risk pools stable and help keep premiums down. I believe I mentioned earlier, Covered California attributes its marketing in 2015 and 2016 to a reduction in 6 to 8% in premiums. So advertising can pay off in terms of sort of bringing in younger and healthier people who need coverage for themselves, but also help the risk pool.
Now, Ms. Keith, can you describe how what you just described, younger, healthier patients not enrolling, how that affects other Americans' ability to get comprehensive health care?
Sure. By not having younger and healthier folks in or having fewer and fewer new enrollees, there's a possibility that premiums will increase.
Okay. Ms. Altman, what's the level of awareness among consumers in Pennsylvania, for example, about the ACA and their health care options in the ACA marketplaces?
I would say that my experience in speaking to Pennsylvanians is very reflective of the study that Ms. Keith mentioned. In particular, there seems to be a significant lack of awareness about the financial support available under the Affordable Care Act. Many consumers come to enrollment events and think there is no way they will be able to afford the coverage, only to find out that it is all more affordable than they ever thought it could be.
Thank you. And also, Ms. Turner, you mentioned something that as a former business owner, on the face of it, I would probably agree with, but I don't agree with in this case about how we're trying to provide comprehensive health care to as many Americans as possible. And I quote, individual patient choice. When I was a little boy, my parents had an individual patient choice, and they chose to go without insurance coverage because it was too far out of reach for my family's single income, first grade education immigrant father who was a gardener. He couldn't be a CEO, didn't aspire to be or what have you, but he provided food on the table for 13 people every single day, and I'm so proud of him and my mother for doing what they could with what little they had. Also, my parents' individual choice was to not participate in preventative medicine practices like going to see a doctor, because even that was too expensive for us to do as a low-income family. My parents' individual patient choice was to look at us and pray for us when we got a bad fever or something, and then now and again, once in a while, say, it's time to go. Time to take us to the emergency room, not to our regular care doctor, not to a place where we could actually be preventative in these measures, but the dangerous choice of waiting to the last minute to decide, I think my child is in very serious danger. Now it's time to go to see a doctor. That is individual choice that the Affordable Care Act as flawed as it is, has been trying to overcome, and it was able to overcome that for tens of millions of people that before were like my family when I was growing up. Thank you very much, Madam Chair. I yield back.
I thank the gentleman. You just saw and heard passion on display. Now we have two members that have been waiting very, very patiently. They're members of the full committee. Ms. Schakowsky is also a chair of a subcommittee, and the rules of the committee allow for members that are not part of this subcommittee to come and to participate, but they have to come last. So thank you to the gentlewoman from Illinois, and for her great service on this subcommittee in previous Congresses. I recognize her for 5 minutes of questioning.
I thank you, Chairman Eshoo, for allowing me to wave on to the subcommittee, a subcommittee I served on for 16 years, and I'm happy to be here today. I just wanted to point out that the state of Illinois passed legislation preventing these short-term, we call them junk plans, because there was a robust debate about those. And while we saw a 7% lower enrollment, I think it could have been even higher had that we could have done better had the I do call it sabotage of limiting the navigators. Ms. Turner said that only 1% of the navigators had anything to do with it. Has the public program that was essentially defunded been helpful, and would we have had more enrollment had we had the dollars to advertise the programs? Both of you, actually.
Absolutely, and I think when we talk about navigators, who we're really talking about is community-based organizations, United Ways, legal aid societies, American Cancer Society, organizations like that who are sort of bedrock institutions in the community. Although some of that data I think has been disputed on navigators, I will say under the statute, enrollment is only one of the 5 things that navigators are supposed to work on. Their real goal is to help folks with limited English proficiency, lower income folks. They have a lot of other things they're doing that aren't just enrollment. So I think having those navigators there is really helping families with complex conditions, families who need a little bit of extra help to get enrolled. And then to your question, I tend to agree. If we had outreach and marketing funding, the marketplace has sort of remained stable even with these cuts. But at least one study has showed that we should have 2.3 million more new enrollees at a minimum. So the marketplace should be much bigger than it is.
Just speaking for Pennsylvania, I can say that the navigator organizations in Pennsylvania are incredibly committed and incredibly effective in reaching people and helping the most challenged individuals through their healthcare questions and issues, and enrolling people both in the marketplace and in Medicaid as well, particularly with the expansion, and especially in reaching groups of people who are not going to be reached otherwise. Those who have specific healthcare needs. One of our navigator organizations focuses on individuals with mental health conditions, focusing on groups for whom English is not their primary language. We have other navigator organizations focused on certain communities in that category, and so they do fill a very unique void.
Let me interrupt. I have little time left. I wanted to refer to a bill, H.R. 1143, that Representative Eshoo sponsors, but I wonder if either of you are knowledgeable about the Georgetown University Health Policy Institute findings about really what has happened when brokers are telling people about these plans, and how they concluded that insurance brokers selling these plans engaged in deceptive marketing practices.
Thank you for that question. This was a study done by my colleagues on the really aggressive marketing and outreach we've seen of short-term plans. By and large, there's a lot of ads funded going towards marketing of these short-term plans. Brokers, we found instances where brokers were very aggressive by phone. You have a lot of robocalls, brokers who would really wanted someone to purchase while they were on the phone and refused to provide written information at all. you're seeing plan or websites, web brokers saying that they sell ACA plans and short-term plans, but then only allowing enrollment in short-term plans.
And did some of those people think they were getting a comprehensive ACA plan?
I'm sure that is true. It's very confusing. The other thing I was going to add is that we've seen steering. So even when patients might be eligible for subsidies or consumers might be eligible for subsidies through the marketplace, being directed to a short-term plan when they might qualify for a much cheaper, more comprehensive policy.
I'll just add very quickly that my department has had to revoke the insurance licenses of a number of agents and brokers who have done exactly what you said and lied to consumers and told them these plans are things that they are not. And it is falling to states to do what we can to be vigilant in a very active marketplace with a lot of marketing that is very questionable.
Let me just say, choice is a good thing. It needs to be informed choice. People really need to know what is going on, and these plans, I'm happy that they were outlawed in the state of Illinois. I yield back. Thank you very much for letting me be here.
Thank you for your patience and your attendance. I now would like to recognize another member of the full committee, not of the subcommittee, but always welcome here, and a new member to the full committee, the gentleman from Florida, Mr. Soto. You're recognized for 5 minutes. We're going to vote pretty soon, too.
Yes,
yeah.
I will be efficient. Thank you, Chairwoman Eshoo. So sabotage of the ACA, allow me to count the ways. Let me just go through the top 5 as I see it. First, eliminating cost-sharing subsidies that raised rates. Second, cutting enrollment period in half. Third, cutting marketing dollars in half or more. Fourth, eliminating high-risk corridors, hurting competition. And fifth, eliminating individual mandates. One that we still need to talk about is there was an attempt to eliminate pre-existing conditions in the Trump Care bill that did not pass, thank God. But if we didn't stop them, we would have saw even that sabotaged. I think all parties can agree this was a big issue in the last election and that Americans want us to get to work and bipartisan solutions on it. I come from the state of Florida, home to the largest federal exchange in the nation. 1.7 million Floridians are on the ACA exchanges, up 50,000 from last year. So first I'd like to get a potential consensus here from the witnesses. Yes or no, did eliminating the cost sharing by the Trump administration in the last Congress raise rates altogether? Yes or no? And we'll start with Ms. Keith.
Yes, it did.
Ms. Altman.
Absolutely.
Ms. Turner.
It was not, funding was not included in the original law, and this Congress was trying to provide the funding in context of larger reforms.
So I'll take that as a no. Okay. And then for my second and final question, why would a state like Florida still have an increase in ACA enrollment even with these 5 clear sabotages of the ACA? Opinions. We'll start with Ms. Keith.
One response is that there is still continued demand for the type of coverage that the ACA provides for comprehensive, affordable, quality coverage. At the same time, you still have subsidies available for most folks who enroll through the marketplace, and that has been, I think, the enduring stability of these programs.
Ms. Altman.
Just reiterating, I think that demonstrates the value proposition that the comprehensive coverage along with the financial assistance available on the marketplace provides to millions of Americans.
And Ms. Turner.
Maybe sort of ending on a bipartisan note, there's such broad agreement that we need to help people to purchase coverage who are shut out of the market for whatever reason and make it more affordable. I would hope to work with you in doing that.
Just to conclude, you know, Florida is a giant state, 3rd largest in the union, and a lot of our constituents don't have access to the foundational plans of this nation, employer-based plans that so many Americans are on, particularly because they may work in the service industry or the agriculture industry, which is why the ACA continues, despite all the sabotages, to be a smashing success in my state, because this is really the only option people have. So from Florida's perspective, we cannot let this fail, and despite attempts to make it fail, it has still thrived for us to still be the largest federal exchange in the nation. So I look forward to hearing from all of you all now and in the future and work with the committee, and thank Chair Eshoo for the opportunity. And with that, I yield back.
You're always welcome here. I think that this is, we have concluded the questioning of both the guests of the subcommittee and all the members. I want to thank the witnesses again. I think that each one of you did an outstanding job. I don't necessarily agree with you, Ms. Turner, but you worked hard to answer the questions, and I certainly appreciate that. I also want to thank the authors of the legislation. They're not here now, but I think to say this for the record, that they have worked hard on these bills, and I want to thank Congresswomen Custer, and Blunt Rochester. And I also would like to ask for unanimous consent to place into the record the following: the letter of endorsement from the AARP for all of the bills that were discussed today, a letter of endorsement from the American Academy of Physicians, the testimony for the record from Sam Blokel, the letter of endorsement from the Federation of American Hospitals. That's an endorsement of the legislation that was discussed today. The same from the American Medical Association on the 4 bills. The letter from the American Lung Association in support of H.R. 987. Letter from the American Lung Association in support of H.R. 1010. Statement from the American Lung Association in support of legislation repealing 1332. Statement from the American Heart Association in support of H.R. 1010. Statement from the American Heart Association in support of H.R. 986. Statement for the record from the Association for Community Affiliated Plans. The statement for the record from the America's Health Insurance Plans. The letter from 23 health partners and patient advocacy groups to the Trump administration expressing strong concerns with the Section 3032 waiver guidance. A letter from 23 health partners and patient advocacy groups to the Trump administration expressing strong concerns with the short-term limited duration insurance final rule. A letter from the American Hospital Association, and a statement of support from Families USA. Without not hearing any opposition, these items will be placed in the record, and I'd like to recognize Dr. Burgess for his request for items to be placed in the record.
So, Madam Chair, I have a unanimous consent request to place into the record a statement for the record submitted by the Coalition to Protect and Promote Association Health Plans. I also would like to submit for the record an article from the Washington Post. The Health 202 Association Health Plans expanded under President Trump look promising so far, and I appreciate your offer to have a hearing on association health plans. We have heard some discussion about lifetime limits, and I would point out that even under Medicare, there are sometimes what are called therapy caps. Therapy caps were repealed for physical therapy and occupational therapy last year in the Bipartisan Budget Act of 2018, but I would just like to submit for the record the members of the committee who voted against that and therefore voted against repeal of therapy caps in the Bipartisan Budget Act, and I thank you for the consideration. I'll yield back.
Thank the gentleman. We don't often enough say thank you to the staff, to the committee. And so on behalf of all of the members of the subcommittee, I want to thank both the majority staff and the minority staff for the work that they do to help prepare us, to bring the witnesses forward, to draw up some of the talking points and the answers to questions that may be asked. And it's a sincere thanks from all of the members of the subcommittee. So with that, I think we will make it over to the floor and maybe even be there, Dr. Burgess, before the bells ring. Thank you again to the witnesses, the time that you have given to us, and your commitment to these issues by dedicating your lives to them. That is, in no small measure, I think, a gift to the country.
Do we have 5 legislative days to submit questions for the record?
We do, and we have 10 business days to submit additional questions for the record, to to be answered by the witnesses who have appeared. And of course, we trust and I ask that the witnesses respond promptly to any questions that you may receive. And we've already placed what we wish to place in the, into the record. So at this time, the subcommittee is adjourned.
So